మధ్యలో మిడిల్ వేసారు కొద్దిగా. అవునా?
Good morning, respected dignitaries, esteemed faculty and dear colleagues. It gives me immense pleasure to welcome you all to the academic CME program on recent advances in neurology and neurosurgery, organized by Kamineni Hospitals in association with Amaravati Association of Neuroscientists. Medicine is not a static science, it evolves every day. And today we gather not just to listen, but to rethink, relearn and refine our clinical practice. On behalf of organizing team, I extend a warm welcome to each one of you.
Let's take a moment to acknowledge our respected leadership and guiding forces. Now I welcome Dr. Vardhan Garu, our Medical Director of Kamineni Hospital, to speak a few words about CME.
Good morning, respected dignitaries, for coming all the way to this CME on recent advances in neurology and neurosurgery. Before starting this introductory speech, I would like to extend my wholehearted thanks to Dr. Jalil sir and Dr. Lavanya madam for coming all the way from Hyderabad to guide us and to discuss on the recent advances in some important neurology topics. As we know that in recent years, every year some new drugs are coming. And I always remember my HOD saying that a clinician might know all the drugs, but a good clinician will know when to use and how to use and what are the side effects. So in Kamineni, our MDs are always asked for conducting CMEs and to excel in the academic aspect rather than just practicing every day. So as we have DNB also in our Kamineni hospital in neurology, ortho and general medicine, we are very happy to conduct regular CMEs only for academic interest, not for any other purposes. So I would like to thank all the dignitaries and all the participants who have come on Sunday despite their holiday and spending their time to know about the recent advance in neurology and neurosurgery. And I always be humble and thankful to all our neurology and neurosurgery departments for accepting our proposal to conduct the CME. We have got a good blend of experience as well as youth. And before we dwell into the current CME program, I wish you all the best, and I hope that the CME will be useful for all the neurologists and neurosurgeons in their day-to-day practice. Thank you all, and without wasting much of the time, we'll start the proceedings. Thank you.
Stroke care has undergone a revolution in recent years. Time windows are expanding and outcomes are improving. To enlighten us on revascularization in acute ischemic stroke and expanding treatment windows, I invite Dr. Arunakumari Madam to speak on revascularization in acute ischemic stroke and expanding treatment windows.
Oh shit. Sit.
Excuse me.
Dr. Aruna Kumari Madam, MD, DM Neurology, Professor and HOD of Department of Neurology in Siddhartha Medical College. Now ma'am speaks about the stroke.
A very good morning to one and all. Today's topic is revascularization in acute ischemic stroke, expanding the treatment windows. This is after the recent guidelines that came into force in the 2026 this year. Acute ischemic stroke is a major cause of death and long-term morbidity. These 2026 guidelines have 6 subsections. First one is, as we all know, the introduction and the committee formation, etc. And out of the all, class of recommendations and level of evidence is important one. In class of recommendation, as everyone know, class 1 is benefit is much superior than risk, and class 2A is benefit is more superior than risk, whereas class 2B is weak evidence and benefit is more than risk, whereas class 3 is benefit is equal to risk. So we have to be very careful while selecting the options in class 3 recommendations. In class 3 harm, that is strong recommendation that causes harm. That's why risk is more than benefit, and we should not take this as treatment option. In the second subsection, the stroke awareness, that is a public awareness programs and pre-hospital assessment, that is by the paramedics, and hospital stroke capabilities, whether that hospital is capable of doing CT scan or MRI or perfusion imaging or diffusion imaging, etc. And whether the hospital is having neurologist or physician who have trained in stroke medicine and who can give thrombolysis, or whether that hospital is capable of doing endovascular treatments. And emergency evaluation of patients with suspected stroke. This is without wasting much time in the emergency department and in the imaging room. The decision should be taken immediately by the physician, and it should be a shared decision. That means that should be discussed, the pros and cons should be discussed with the patient or with the caregiver and then taken. Telemedicine. Recently, the telemedicine is also one of the important part. That is, with the though the center is hospital or center is having CT scan facilities, that should be, if it is a remote area or far from the higher centers, then the CT scan should be uploaded in the phone or system to the consultant neurologist who is residing at a far distance. And they will discuss with the treating physician there by phone or by video call, so that examination can be performed and decision can be taken whether to thrombolyze or not. The third subsection is emergency evaluation and treatment, different stroke scales. In the stroke scales, NIHSS is more important one. NIHSS have some limitations. That is, this is basically for anterior circulation stroke. There are lacunae in evaluating posterior circulation stroke in NIHSS. In same way, left-sided strokes are better evaluated with NIHSS, whereas right-sided strokes are less evaluated. So these are the lacunae, or these are the pitfalls of NIHSS score. Then modified NIHSS can be taken, but it also cannot fulfill all the requirements. In pediatric cases, recently 2026 guidelines, pediatric thrombolysis is included. Previously, it was not recommended, but in these guidelines, it was included. So pediatric NIHSS demonstrates high inter-rater reliability in limited studies, because previously no thrombolysis, so no NIHSS scales were performed in pediatric cases. That is one thing, and the other one is pediatric strokes are less in number. So the studies evaluation is not completed. We hope that they will come in the future. Initial brain imaging. In the brain imaging, as we all know, non-contrast CT is the most important one. If MRI is present and it will be done within 25 minutes, then we can go for MRI. Otherwise, non-contrast CT is sufficient to take the decision of thrombolysis, or to do or not to do thrombolysis. And renal function test should not delay the imaging. CT perfusion or CT angio, if needed, we can do without waiting for the renal function test report. And imaging in pediatric acute ischemic stroke. For all the guidelines, the recent one added pediatric. In adults, NCCT brain is enough, whereas in pediatrics, MRI angio of the brain, cervical and intracranial vessels, both is reasonable, because there is no previous well-validated studies. That's why we have to rule out the mimics. That's why we have to take multiple imagings in pediatric cases. CT angio is reasonable when MRI or MRI angio is not available. Whereas in adult cases, NCCT is sufficient. In pediatric cases, MRI, MRA is reasonable. If that is not available in that center, we can go with CT angio. Imaging for extended window IV thrombolysis. This is one of the recently added armamentarium in the stroke guidelines 2026. Extended window IV thrombolysis. Previously, up to 4.5 hours, we can give thrombolysis. Now it was extended. That is up to 9 hours and up to 24 hours. Two components are there. I will discuss in the later slides. Wake up are unknown onset strokes. That is, probably more than 4.5 hours. We don't know when the stroke has occurred. MRI DWI flare mismatch can be useful to select patients for extended window IV thrombolysis. This is class of recommendation 2A, that is benefit is more than risk. And perfusion based selection, CTP or MR diffusion perfusion with automated software analysis can be useful to determine eligibility for extended window IV thrombolysis. So in system we are using many things like this software analysis we can take for diffusion perfusion mismatch, and then we can decide. Imaging for endovascular thrombectomy. It will be discussed in detail by our colleague Dr. Sudhir Chakravarti. I will tell one word. Vascular imaging is mandatory for EVT, whereas for thrombolysis, IVT, intravenous thrombolysis, vascular imaging is not mandatory. For EVT, it is mandatory. And other diagnostic tests like ECG and troponin, we cannot wait for the results, but it must be done. Next subsection is general supportive early management. As we all know, airway breathing oxygenation. In oxygenation, oxygen saturation more than 94% is required. If it is less than 94%, we have to give supplemental oxygen. Hyperbaric oxygen is not recommended if the oxygen SpO2 is more than 94%. And head positioning. The positioning of the head at 0 degrees or 30 degrees or Trendelenburg, whatever it may be, there is no much difference for IV thrombolytic cases. Whereas temporary flat positioning in acute ischemic stroke with LVO before endovascular treatments need further study. That means the results are inconclusive, so further studies are required for this. Whereas for IVT, intravenous thrombolysis, there is no difference with 0 degrees, 30 degrees or Trendelenburg. And BP management. As we all know, as previous guidelines also say, hypotension and hypovolemia should be corrected promptly. And early antihypertensive therapy is indicated only for specific comorbid conditions, cardiac conditions like acute coronary syndrome, heart failure, aortic dissection, or symptomatic intracranial hemorrhage. This is class of recommendation is 1. That means benefit is more superior than the risk. That's why we have to treat with antihypertensives early in the cardiac cases. In patients without reperfusion therapy and BP is less than 220 by 120, routine BP lowering in the first 48 to 72 hours is not beneficial. This is class of recommendation is 3. That means there is no benefit at all. And blood pressure and reperfusion before IV thrombolysis and before EVT. Before IV thrombolysis, BP should be less than 185 by 110. This is class 1 evidence. After IV thrombolysis, BP should be less than 180 by 105 for 24 hours. That's why after thrombolysis, we are measuring the BP every half an hour in the initial and later every hourly, 2 hourly like that up to 24 hours. Intensive SBP less than 140 mm is not recommended, not beneficial. So it should not fall below 140. It should be between 140 to 185, 180. Before endovascular treatments without IVT, endovascular treatment can be combined with IVT. If it is not combined with IVT, then maintaining BP 185, less than 185 by 110 is reasonable. The evidence is 2A, that is benefit is slightly more. And after EVT, endovascular thrombectomy, BP should be 180 by 105 is reasonable. And intensive SBP less than 140 is harmful. In EVT, it is definitely harmful if the BP is fallen below 140. Whereas in IVT, intravenous thrombolysis, that is not recommended. The harmfulness is somewhat less in IVT, whereas it is more in EVT. The temperature management. If fever is present, it should be treated promptly. If any infection is there in the body, we have to identify the infection and proper antibiotics should be administered. Whereas hypothermia, once upon a time, hypothermia is one of the recommended or practiced thing for decrease the deficits. But induced hypothermia or prophylactic fever prevention is not recommended in normothermic patients because there is no benefit, class 3 evidence. And blood glucose management. Hypoglycemia less than 60 should be corrected promptly, and hyperglycemia should be treated to achieve the blood sugar levels 140 to 180. Intensive glucose control with insulin, that is 80 to 130, is not recommended. In one trial previously, the Sampris trial, intensive glucose monitoring and intensive blood pressure reduction are advised, but that trial was stopped in between. IV thrombolysis in acute ischemic stroke. This is the important one and our favorite topic. General principles of IV thrombolysis. Time dependency of benefit. In adults with acute ischemic stroke, the disabling deficits, faster IV thrombolysis improves functional outcomes, irrespective of NIHSS score. This is the class 1 evidence. Irrespective of the NIHSS score. If the next comes the imaging findings also. In CT imaging, if hypodensity is more, we should not give thrombolysis. That is, the benefit is less. Whereas, if the CT is showing no much hypodensity, then this comes in the way. Irrespective of the NIHSS, the functional outcomes will be better if thrombolysis is given as early as possible. And do not delay the IV thrombolysis for advanced imaging. In view of advanced imaging, like MRA or CT perfusion, we should not delay the IV thrombolysis. Those are required and mandatory for EVT, but not for the IVT. So we should not wait for IV thrombolysis. And those things to give in IV thrombolysis. Preparedness for complications. Each and everything, even simple tablet of B complex or paracetamol also have complications. Likewise, thrombolytic agents. So we are supposed to be prepared, and we have to educate the patient or the attendants in the form of informed consent before administering IV thrombolysis. Bleeding may be risk or angioedema may be risk, like that. And shared decision making. Risks and benefits of IVT should be discussed with, if the patient is competent, with the patient only we can discuss. Otherwise, the caretaker. Metabolic assessments. The mandatory metabolic assessment is blood glucose. All others are not mandatory, including renal tests are not mandatory. But blood sugar levels is mandatory. That can be done in the ambulance itself. GRBS, glucometer monitor. The blood sugar must be measured before IVT to identify hypo or hyperglycemia that mimic the stroke. In pediatric cases, it is much more important. Stroke mimics are more common in pediatric cases when compared to adult cases. And IVT, despite corrected dysglycemia, then only we can, if the hyperglycemia or hypoglycemia is corrected, and even then the deficits are present, then only we can go for IV thrombolysis. Imaging-based eligibility. Early ischemic changes. IVT is recommended in eligible patients with mild to moderate early ischemic changes, excluding frank hypodensity explaining the deficit. As I told you previously, the imaging criteria. Frank hypodensity means large vessel stroke. There, we cannot jump into IV thrombolysis. We should take vascular imaging also, and whether bridging therapy is required or IVT, EVT, both are required. IVT followed by EVT, then the decisions are different. So, don't jump into IV thrombolysis if the hypodensity is more in CT. Mild non-disabling deficits. IVT is not recommended in patients with mild non-disabling deficits. That means NIHSS is less. We should not go for IV thrombolysis because the benefit is not much. with aspirin or with clopidogrel, dual antiplatelets, the benefit is equal with IV thrombolysis. So unnecessarily, we should not administer IV thrombolytics to the patient. Dual antiplatelets is sufficient in these cases. Bleeding risk. Antiplatelet therapy. IVT is recommended in patients on single or dual antiplatelet therapy despite increased symptomatic ICH risk. This is, we should remember this. Class 1 evidence. IVT is recommended even though patient is on single antiplatelet or dual antiplatelet. If the patient gets again stroke, we have to administer IVT. If the patient is dual antiplatelets for cardiac cause, the patient gets stroke, we can administer. Not within the 90 minutes, that can be dealt in the later slides. Laboratory testing. IVT should not be delayed awaiting coagulation or hematologic tests. As I told you, blood glucose is the mandatory, other tests are not mandatory. We should not waste time. And cerebral microbleeds. If the cerebral microbleeds are present, proceed with IOT without considering or without giving much importance to them. If the microbleeds are 1 to 10, the intermediate risk. Whereas if the microbleeds are more than 10, then symptomatic ICH risk will be more, but we have to weigh the risk-benefit ratio there. Pediatric thrombolysis. This is the recently added one. In children 28 days to 18 years age, in confirmed acute ischemic stroke cases, within 4.5 hours window period and disabling deficits. Extended window period is for adults. For pediatric cases, 4.5, up to 4.5, because newly we are introducing this therapy to the pediatric cases. No randomized trials prior to this. IV alteplase may be considered. Safety appears acceptable, but efficacy remains uncertain. That's why class 2B evidence. This is class 2B evidence. The clearly disabling deficit means complete hemianopia, severe aphasia, severe neglect or extinction, any weakness limiting effort against gravity. These are considered as clearly disabling deficits. And we have to know mild deficit and clearly disabling deficit. If disabling deficit is there, even though NIHSS is less, we can go for IVT. Often non-disabling, that is isolated facial droop, mild aphasia, mild sensory loss, mild distal weakness. In these cases, we should not incorporate IVT and we can go for dual antiplatelet therapy. Management of IVT-related complications, symptomatic ICH, stop thrombolytic infusion, urgent lab tests are required, and non-contrast CT emergency. Cryoprecipitate to maintain fibrinogen more than 150 mg per deciliter. Serum fibrinogen levels should be checked repeatedly, and tranexamic acid or epsilon aminocaproic acid if blood products are delayed. And hematology and neurosurgical consultation is taken urgently. Aggressive supportive care, maintenance of BP, ICP, glucose, temperature, everything should be taken care of. And oral lingual angioedema is one of the complications with IV thrombolytic agents. The secure airway and stop IVT, discontinue ACE inhibitors if the patient is on ACE inhibitors, and administer steroids and antihistamines. If the angioedema is progressing, go with epinephrine. And still it is not responsive, then consider icatibant or C1 esterase inhibitor in refractory cases. And choice of thrombolytic agent. Recommended agents, alteplase and tenecteplase as we know. Alteplase 0.9 mg per kg or tenecteplase 0.25 mg per kg, maximum 25 mg. And high dose tenecteplase means 0.4 mg per kg is not recommended. There is no benefit with high dose tenecteplase. That's why we should go with 0.25 mg per kg tenecteplase only. Thrombolysis in cerebral microbleeds, as I told you previously, and tenecteplase versus alteplase. Tenecteplase is superior in recent trials than alteplase. And IVT dosing in high bleeding risk patients. Whether lower doses of tenecteplase can reduce hemorrhagic risk while preserving efficacy is unknown. That's why low dose is efficacious or low dose will cause less bleeding is not a dictum. And bridging thrombolysis before EVT. As I told you, mandatory vessel wall imaging should be taken, and then go for EVT, IVT bridging therapy. Post-thrombolysis monitoring and pediatric thrombolysis, especially with tenecteplase. Data are extremely limited on safety, dosing, pharmacokinetics, and efficacy of tenecteplase in children with acute ischemic stroke, because alteplase is used for long time in adults, and now alteplase is recommended in pediatric cases. Tenecteplase is recommended in adults in recent days only. That's why the trials should be done in pediatric cases also. At present, tenecteplase in pediatrics is not safe, and alteplase we can go with. Tenecteplase efficacy in patients with high cerebral microbial burden, as I told you previously. Extended time windows for intravenous thrombolysis. This is the actual topic. The previous ones are for the guidelines and recommendations, but the topic given for me is extended time windows. Wake-up stroke or unknown onset. That is, if the stroke onset is unknown, that is whether it is more than 4.5 hours or 6 hours or 9 hours, we don't know. In those cases, IV thrombolysis is reasonable in patients with unknown onset, but within 4.5 hours. That is universally acceptable as previous guidelines. But in unknown time window, diffusion-weighted lesion, less than 1/3 of MCA territory, we can go with thrombolysis. No marked flare hyperintensity, that is DWI flare mismatch is present, improves functional outcomes, then also we can go with IVT. These are the recent guidelines. Diffusion flare mismatch, we have to see. That's why MRI is needed in these cases, whereas within 4.5 hours CT is sufficient. Extended window 4.5 to 9 hours. This is perfusion-based selection should be taken. IV thrombolysis may be reasonable in patients with salvageable ischemic penumbra on CT perfusion imaging or MR imaging with DWI diffusion perfusion mismatch. Wake-up stroke within 9 hours from sleep midpoint or 4.5 to 9 hours from last known well, we can take CTP or diffusion flare mismatch and diffusion perfusion mismatch. And in some cases, diffusion flare mismatch also we can take. Some trials are going on with diffusion flare mismatch. Very late window, that is 4.5 to 24 hours. With large vessel occlusion and no EVT access, then what should we do? IV thrombolysis may be beneficial. That means evidence is class 2 to 3A. That's why we can go with IV thrombolysis. LVO with salvageable penumbra. The beyond thrombolysis window, that is beyond standard window, 4.5 hours, always vessel wall imaging or diffusion perfusion or CT perfusion is mandatory. LVO salvageable penumbra is present, then we can go with IVT if EVT is not available. Other IV fibrinolytics and sonothrombolysis in acute ischemic stroke. Retiplase is the other one, and evidence is class 2B only. The Chinese RCT are going on, and along with retiplase, one Chinese herbal medicine trials are also going on. They will come into force in next 1 or 2 years. Mutant pro-urokinase. This is non-inferior functional outcomes, but the evidence is less. That's why mutant pro-urokinase may not be useful at present condition. Other fibrinolytic agents which are not recommended are desmoteplase, mutant pro-urokinase plus low-dose alteplase, urokinase, streptokinase. Streptokinase is harmful. That's why you should not attempt for streptokinase at any time for brain stroke. Sonothrombolysis. As adjunct to IVT, there is no much improvement with sonothrombolysis plus IVT. That's why the recommendation is class 3 and there is no benefit. IV thrombolysis in other specific circumstances like sickle cell disease, central retinal artery occlusion, branch retinal artery occlusion, and after recent DOAC exposure. In sickle cell disease, the level of evidence is class 2A. The mild benefit is there. That's why we can go with IV thrombolysis if other criteria is fulfilled. Then only we can go. Acute non-arthritic central retinal artery occlusion. Insufficient evidence is there. Here also the level of evidence, the class of evidence is 2B. That's why may or may not be used. One patient came from LV Prasad Hospital recently to government hospital, and they told that immediately one drug is to be given like that. But the evidence is not much superior. Branch retinal artery occlusion. Role of IV thrombolysis remains uncertain in this also. That's why may or may not be given. Because these are small vessels, and if hemorrhage occurs, the vision will be lost permanently. That's why we have to be supposed to be careful. And endovascular thrombectomy. This will be dealt by our colleague in next topic. Antiplatelet therapy. This is the important one. Early antiplatelet therapy, early secondary stroke prevention, dual antiplatelet therapy, and antiplatelets in the setting of IVT. Early antiplatelet therapy within 48 hours, aspirin. Aspirin should be administered within 48 hours, 325 mg. And antiplatelets after IV thrombolysis. Antiplatelet therapy is not recommended within 24 hours. After 24 hours, we can give. And glycoprotein 2B3A inhibitors, tirofiban, epsiximab. Tirofiban, the evidence is 2B, whereas epsiximab 3, and it is harmful. So only tirofiban we can give, but the role is not well established. That's why aspirin, clopidogrel, or aspirin is superior than any other drugs. Early secondary stroke prevention. Non-cardioembolic stroke, the antiplatelet therapy is preferred over anticoagulation in non-cardiogenic, whereas in cardioembolic, antiplatelet plus anticoagulation or anticoagulation is sufficient. Stroke on aspirin, that means aspirin failure. If the patient is taking aspirin but stroke recurs, what should we do? Increasing aspirin dose or switching agents has uncertain benefit here also. But we have to go with increased dose or dual antiplatelet. Better is dual antiplatelet. Harmful or ineffective strategies. Ticagrelor versus aspirin, there is no benefit, and triple antiplatelet therapy is harmful. So only dual antiplatelet is advised anywhere, but triple antiplatelet is always harmful. And antiplatelet and anticoagulation in AF patients without CAD or stenting is also harmful. If AF is present, this combination is preferable. If stenting is done previously, this combination is preferable. Without AF, without stenting, this is not advisable. Dual antiplatelet. Anticoagulant therapy, early anticoagulant. If cardiac indication is there, then only early anticoagulation are recommended. But in special situations, benefit of urgent anticoagulation is uncertain in high-grade ICS stenosis. Even though ICS stenosis is high-grade, the anticoagulation is uncertain, but if the symptomatic or asymptomatic side, we have to check and then go along with the guidelines. In next topic, it will be covered. Non-occlusive intraluminal thrombus, safety and efficacy, the evidence is 2B. Hemorrhagic transformation, evidence is 2B. Argatroban, there is no benefit with argatroban, so the drug should not be given. And anticoagulants, factor 11A inhibitors, asundexian. Recently the trial was completed, and it was the trial protocol, the trial results were published and presented in the WSO conference. And optimal early versus delayed anticoagulation selection tools in the AF. In AF also, the asundexian factor 11A trial was done, and in stroke also done. Hemodynamic augmentation and neuroprotective agents, the volume expansion, as we all know. And mechanical hemodynamic augmentation, the mechanical strategies are not recommended. Counterpulsation devices and sphenopalatine ganglion stimulation, these are all tried, but there is no much evidence. Neuroprotective agents like hypothermia, free radical scavengers, anti-excitotoxic, anti-inflammatory, mitochondrial stabilizers, conditioning strategies, these are all not recommended. And confirmatory trials for promising agents, the last one, nerenitide, uric acid, edarvan, and epitol. These are the drugs which are under trials, but no promising evidence till now, and no RCTs, class 1 evidence is not there. Emergency carotid revascularization without intracranial occlusion in stroke. Here also the evidence is class 3, there is no benefit. In hospital management, stroke units are necessary. In stroke units, different types of stroke units for comprehensive stroke care. Acute stroke units, rehabilitation stroke units, comprehensive stroke units, and mixed stroke units, different types of stroke units in Western society. But here we are not having all these types. Dysphagia management. If the patient is having dysphagia, bedside swallowing screening should be recommended, and dysphagia screening by speech pathologist or speech therapist is advised. And nutrition. Enteral nutrition within 7 days is recommended if the patient condition is comfortable. Whereas if dysphagia is present, nasogastric feeding is initiated within first 7 days. Whereas if nasogastric feeding is also not permissible, then PEG tube can be inserted. DVT. DVT prophylaxis, intermittent pneumatic compressions, there is level 1 evidence. Whereas prophylactic dose of unfractionated heparin or low molecular weight heparin, the evidence is level 2B, class 2B. And superiority of low molecular weight heparin over unfractionated heparin is not there. Either is both are same. And elastic compression stockings are not advised because it is harmful. Only intermittent pneumatic compression is more superior. Post-stroke depression can be treated, but validated scales are not approved. As the psychiatry people taken, we can also follow them. Other in-hospital management, this is palliative care resources, etc. And routine prophylactic antibiotics are not beneficial, whereas routine indwelling bladder catheterization is harmful. So, no antibiotics, no catheter. Rehabilitation after ischemic stroke. Here rehabilitation centers are very limited in our country, but in Western countries rehabilitation centers are much more and they can be admitted there. Treatment of complications, brain edema. For brain edema, the osmotic therapy, the class of evidence is 2A, and glibenclamide, there is no benefit with glibenclamide. Some trials are there, but there is no benefit. That's why we should not use glibenclamide. Hypothermia barbiturates, there is no evidence and harmful. They are harmful. That's why once upon a time hypothermia is advised, but that is harmful. And supratentorial infarction, this is one of the, with edema, decompressive craniectomy, hemicraniectomy is recommended. Cerebellar infarction with obstructive hydrocephalus or brainstem compression, the decompressive craniectomy or ventriculostomy depends on the condition. Seizures after stroke. Unprovoked seizure after ischemic stroke, anti-seizure medication is recommended based on individual patient characteristics. The drug should be tailored. This is class 1 evidence. Whereas prophylactic anti-seizure medication, there is no benefit. That's why don't write prophylactic anti-seizure medication. At the conclusion, acute ischemic stroke care is now evidence-driven and systems-based. Endovascular thrombectomy has expanded beyond anterior circulation stroke with proven benefit in selected posterior circulation, that is basilar artery occlusions, and emerging but limited evidence in pediatric cases. And many commonly used adjunctive therapies lack benefit of cause or harm. That's why we should not use neuroprotective agents or hypothermia, etc. And significant knowledge gaps remain, particularly in pediatric and posterior circulation stroke. Hope they will come in the recent future. Next. Thank you, one and all. Any questions? If any queries are there, you can ask. Sir. ఎంత టైం అయింది? టైం ఎంత అయింది? 45 minutes అయిపోయిందా?
Good morning, madam. I'm Dr. Gopal Sivanarayana.
Sir, good
A
morning.
nice presentation. And I'm asking about citicoline and pyricetam for the benefit of the general public and practitioners. And this is the most costliest part of treatment in the acute stroke management among the public, and including the unfortunate by neurologists also. What is your opinion about citicoline and pyricetam? And what I read in the textbook, citicoline actually withdrawn from the trials itself, even the basic study level itself is on withdrawn. It gave a very negative result. But there is no prescription without giving a citicoline or pyricetam, even from the referred institutes also. So this is the pathologic situation. What is your comment about it? Citicoline and pyricetam.
Citicoline and pyricetam, individual drugs are in combination. There is no class 1 evidence or class 2 evidence. That's why class 3 may be there in some trials, that is small trials, but not multi-center randomized trials. So we should not use as per the guidelines. As per the guidelines, the mild benefit may be there in some cases, but it is not taken to the general public. Thank you, sir. ఓకే, అది ఆపేసినట్టున్నాడు. ఓకే, సరే, తర్వాత.
Thank you, ma'am, for that highly informative and thought-provoking session. Your talk has clearly highlighted how evolving stroke strategies are transforming the patient outcomes and expanding our clinical possibilities. Now I welcome Dr. Vadan sir to kindly present a memento to Dr. Arna Kumari ma'am as a token of our gratitude. Memento, ma'am.
టైం కలిసి వచ్చేది. నెక్స్ట్ టైం చాలా చూసుకోండి. ఇద్దరికి ఒకసారి ఇస్తే టైం కలిసి వస్తుంది.
Next session. Thank you, ma'am. Thank you, sir. Stroke Kit today is no longer just about early arrival. It's about identifying salvageable brain and acting decisively. With that, now I invite Dr. Sudhi Chakravarti sir to share his insights on advanced stroke management and evolving revascularization strategies. Okay, sir. 1 minute. Dr. Sudhi Chakravarti sir is an interventional neuroradiologist and neuroendovascular therapist. Thank you.
Focus.
Good morning, everybody. Thank you for inviting me to this stroke session. I will be talking on the endovascular management of acute ischemic stroke. The medical management part was very well described by Dr. Aruna madam. So we'll look into the next phase of the treatment. So all the treatment is based on identifying the caliber of the vessel, the large vessel or is it a medium vessel. So all the large vessel occlusions, they need endovascular treatment. So what do you mean by a large vessel? The ICAs, the vertebral basilar, they are all the large vessel. The MCI M1 segment will be considered as a large vessel, and the rest of all are medium vessels. The ACAs, the A2, M2 and P2. For all the large vessel occlusions, endovascular treatment is invaluable. So there are different strategies in managing large vessel occlusions, doing a thrombectomy or doing balloon angioplasty, stenting, or sometimes we go for intra-arterial thrombolytics. So IV thrombolysis, we consider it as the first line treatment in acute ischemic stroke, but it has many limitations. The many limitations like the time window should be less than 4.5 hours. The efficacy, especially of IV thrombolysis, is very poor, especially in large vessel occlusions, and there are many exclusion criteria. If you look at the revascularization rate just with IV thrombolysis, it's very poor. For the MCA, it's like 30%. If it is the main ICA, it's only 10%. So there were many studies comparing IVT versus EVT, IV thrombolysis versus endovascular. The benefit with endovascular has been proven beyond doubt. Why is it so? Because of the large clot burden, IV thrombolysis will be ineffective. If the clot burden is more than 8 millimeters, IV thrombolysis is not going to work. So all of them, they have to be taken for endovascular treatment. So what's the stroke treatment algorithm? Whenever we see a patient with symptoms of acute stroke, we proceed with imaging, either with a CT or an MRI. And if it is a hemorrhage, the treatment line is completely different, and we will be dealing with acute ischemic symptoms in this presentation. So if there is presence of ischemia, you look at the time. If it is less than 4.5 hours, we check for the eligibility of IV TPA. If it is eligible, we give tenecteplase or alteplase. And soon after IV thrombolysis, we go for vascular imaging, CT angio, MR angio, or a DSA. If there is a large vessel occlusion, we go for thrombectomy. If the patient is ineligible for IV thrombolysis, still we go for thrombectomy. If it is beyond the 4.5 hour time window, but it is less than 24 hours, we do perfusion imaging, CT perfusion or MR perfusion. We look at core penumbra and go for a thrombectomy. If there is no large vessel occlusion, then we look into the other treatment like antiplatelet regimens. So there we look into a few cases of where the IV thrombolysis had many limitations. So one such a case of a 50-year-old diabetic who came with acute hemiplegia of 2-hour duration, NIHS was 12. MRI showed infarct in the right MCA territory. Whenever you look at an MRI, we look at diffusion, we look at flare, we look at some vessels in the MRI. If there is a diffusion-flare mismatch, or if there is a hyperintense vessel, they are all good candidates for thrombolysis or thrombectomy. The MRI angio showed a large vessel occlusion. He was given tenecteplase, but subsequently the infarct progressed, had worsening of clinical symptoms. He had to undergo a decompression. So, and he had long-term disability. So in this case, tenecteplase IV thrombolysis was ineffective. We look at another example of a 40-year-old lady who came with left hemiparesis of 2-hour duration. CT was normal, received IV thrombolysis, vascular imaging or further imaging couldn't be done due to technical issues. Her sensorium worsened, progressed, large infarct, decompression, and she was disabled for the rest of her life. IV thrombolysis is not the panacea for treatment of all ischemic strokes. And mechanical thrombectomy should be considered as and when needed. Who are all the candidates? All those with exclusion for IV thrombolytics, large vessel occlusion, those who present beyond the 4.5 hour time period, and in dominant M2, only in medium vessel, only with a dominant left MCA M2, they can be considered for thrombectomy. For the non-dominant, medical management should be enough. How thrombectomy is done, just an animation video. You can see most of the procedures are done with the femoral route. For suppose if a thrombus gets lodged in the MCA, we go through the femoral axis, we reach the target vessel, stent retrievers or aspiration catheters retrieve the clot, and only then we can improve the perfusion to the brain. Only if you get a complete recanalization, the reperfusion improves. So the current guidelines, who are all candidates for EVT selection, all those with large vessel occlusion, EVT in less than 6 hours, they are class 1 recommendation, 6 to 24 hours depending on perfusion imaging, class 1 recommendation again. Aspect score irrespective, 3 to 10, everybody can be taken for endovascular treatment. The only prerequisite that was mentioned is that the NIHS score should be more than 6 and a pre-stroke MRS of 0 to 1. So what if the pre-stroke MRS is 2, or what if the aspects is less than 3? The benefit is equivocal. And then what if the in medium basal occlusion, only if there is a dominant M2, endovascular treatment is shown to be beneficial. If there is a non-dominant M2, or if it is ACI or PCA, there is no clear benefit with endovascular treatment. So these are the current guidelines. So what is any role of EVT in low NIHS? What is low NIHS? We have previously seen that the prerequisite was taken as more than 6. So 0 to 5 is considered as low NIHS. But low NIHS does not always mean low disability. There are certain disabling symptoms and non-disabling symptoms. Even with a low NIHS, if the patient is having blindness, then you can consider it as a disabling deficit with low NIHS. Or if he is aphasic, low NIHS with severe disability. In those patients, we have to carefully select the decision management. Low NIHS does not mean that we have to completely exclude him with endovascular treatment or IV thrombolysis. Each and every patient should be weighed, and each and every disability should be given due attention, and then tailor-made approach has to be made. So there are different techniques in mechanical thrombectomy. You can use retrievers, a combination of aspiration catheters and double stent retrievers. We look at a case example of a 50-year-old diabetic. She happens to be a bank manager. She collapsed in her office and she was rushed to the hospital by her colleagues. She had left hemiparesis and aphasia. NIHS at the time of admission was around 14. So soon after this, what we do an imaging. An MRI was done. An MRI, it showed infarct in the left MCA territory, and there is an occlusion of the left M1. Whenever you do, we look at large vessel occlusions, we look at there is a diffusion and flare mismatch. Why you have to look for mismatch is better outcomes with treatment. So what exactly is diffusion and flare mismatch? You have to look at the volume of diffusion and the volume of the flare. And the volume of diffusion versus flare should be less than 1.5. This is what is considered as a diffusion and flare mismatch. So in this case, if the patient came in less than 4 hours, was eligible for IV thrombolysis, we will be giving IV thrombolytics. And there is a large vessel occlusion, the left M1 is occluded, and so we will shift to mechanical thrombectomy. Initially IV thrombolysis was given, and then she was shifted to the cath lab for a thrombectomy. This was the DSA that shows complete occlusion of the left MCA. A thrombectomy was performed, and before doing a thrombectomy, should we wait for the IV thrombolysis action to be finished? I think we need not wait for the IV thrombolysis action to be completed. We can still proceed for thrombectomy despite IV thrombolysis going on or soon after IV thrombolysis. So in this, we could get a complete recanalization. Most of these procedures, we try to do it under sedation. So there will be a lot of movement artifacts, patient tossing and turning on the cath lab table. We somehow managed to finish the thrombectomy procedure as soon as possible. So in this, we could get a complete recanalization, and as we can see that the patient started improving soon after the cath lab. Soon after the thrombectomy, even while in the cath lab, she started, power started improving and she started vocalizing. The MRI done subsequently showed stable clot and the complete recanalization of the MCA. And this was her MRS at the time of discharge. She had an NSS of 1 by 24 hours, and she was soon good enough to attend her professional work in a couple of days. So we look at further limitations of IV thrombolysis if it is more than 4.5 hours time window. This is a 41-year-old smoker who came with right hemiparesis and aphasia. The last known time, last known well was about 8 hours. That was a wake-up stroke. So initially a CT was done, and the CT was okay. Like there was a small infarct in the CT, and as it was a late window, no IV thrombolysis was given, and he was continued on double antiplatelets. His symptoms continued to progress. And as he developed further hemiparesis, an MRI was done. An MRI at that time showed infarcts in the watershed territories, and there was loss of flow void in the ICA, in the left ICA and MCA. So at that time he was shifted for the higher center. At the time of presentation, he had aphasia NHS of 17 and he was at the 18 hours of time window. So what do you do in this late time window? We have to proceed for perfusion imaging. So we have to look at the core perfusion, core and penumbra ratio, and then consider if it is a candidate for thrombectomy. So this was the CT at admission. The CT angio showed the occlusion of the left ICA, but there was some collateral flow to the left MCA. This is the perfusion imaging, a CT perfusion. We look at the core and penumbra ratio, the core volume and the penumbra volume. If it is that is a very good penumbra, the core penumbra ratio is good, then he is a candidate for endovascular treatment. Core is the center of the infarct, that is the irreversible damage. Penumbra is all the salvageable area. We do a thrombectomy to salvage the penumbra. So the recent guidelines, the DAWN, diffuse, all the criteria, they are well established. Even if it is less than, even if it is beyond 6 hours, but less than 24 hours, if it is a favorable core penumbra, thrombectomy should be done. Further, such studies of looking at the areas of hypoperfusion. Some studies have measured the areas of severe hypoperfusion versus the total perfusion. If the areas of severe hypoperfusion compared to the total is less than 0.4, they are having a good benefit, and that also indicates good collateral supply. So in this case, we did DSA. We took him to the cath lab, and we could see that the left ICA is occluded. There are no strong collaterals from the right side. No good collaterals from the basilar as well. So we did a thrombectomy. We tried to recanalize the left ICA. We could recanalize the left ICA and then the left MCA. We had to do a balloon angioplasty as there was a severe underlying stenosis. Soon after we finished, we could get a good recanalization, but there was a residual thrombus in the stenotic segment. So what do we do in this kind of situations? We give tirofiban. We gave tirofiban IV infusion, followed an initial bolus dose, followed by an infusion. This was the MRI done at about 24 hours. There was slight progression of the infarct, but the vessels could be completely recanalized. And there was a gradual improvement in his motor function as well as his speech. This was the MRI that we did at 1 month. That was a stable infarct. We repeated the CT angio and CT perfusion at 1 month. The vessels are completely recanalized and there was no further areas of hypoperfusion. There is no penumbra. So he had a good clinical improvement. This was his MRS at almost 3 months. He had an MRS of 2, MRS of 3. So we look at another case example of a 70-year-old smoker who came with right hemiplegia and aphasia, confusion of 9 hours duration. So this is the MRI at the time of admission. It shows a decent MRI with only watershed infarcts in the left ICA territory. And we look at the flare was looking okay. And apart from the flare, we look at if there are any presence of any hyperintense vessels on the flare. What does that mean? What are these flare vascular hyperintensities? These indicate sluggish flow in the ICS. They do not indicate thrombosis. They only mean that the flow is severely reduced, and if you can recanalize the ICA, the clinical benefit is going to be good. No endovascular treatment or IV thrombolysis was given. He was only given an IV thrombolysis. He was only given on medical management, but he gradually worsened in the subsequent days. Serial CT showed gradual progression of the infarct. He gradually progressed, and by the end of day 10, he had to undergo a decompression. This was a very late time we had to do a decompression. Like usually the decompressions are usually done by day 3 or day 4. But in this case, the decompression was done as late as day 10. And why is this so? This is one case of a slow progression of stroke. They usually indicate failure of collaterals. These patients usually do with endovascular treatment, had a perfusion imaging done on time, and if he had looked at core penumbra, then he could have been salvaged better. I was talking about the flare vascular hyperintensities. You have to look at these flare vascular hyperintensities in each and every MRI of an acute ischemic stroke because they are of very clinical importance. If you find a flare vascular hyperintensity in less than 6 hours, they predict a good outcome. Even it is considered as a good marker for a diffusion and flare mismatch. If you find a flare hyperintensity is persisting beyond 24 hours, then it indicates the vessel has thrombosed and there is no point in doing endovascular treatment. So in each and every MRI, we have to look at the diffusion and flare mismatch. Along with the flare mismatch, you have to look at flare vascular hyperintense vessels. We look at another case example of a 50-year-old diabetic who had giddiness and malaise the previous night. He woke up around 6 a.m. He had while swaying while walking. Caregivers considered that he has some kind of heat stroke or malaise, and he went to bed. At around 2 p.m., a local practitioner saw him that he was having hemiparesis. So he was shifted to the hospital in a very late window. There was a large vessel occlusion, the right MCA got occluded, and a large infarct in the right MCA. As he was less than 24 hours, we did a perfusion imaging. But in this case, the perfusion imaging did not show a great penumbra. The core penumbra ratio was very poor and the core volume was about 100. So as the core volume was high and very poor ratio, we didn't do endovascular treatment. And as expected, his infarct progressed and he worsened and he had to undergo a decompression. But we noticed that even after decompression, the Mars effect was still persisting. So what do you do in these cases? We do something called a strokeectomy. What strokeectomy is that a part of the infarcted brain tissue would be resected so as to reduce the mass effect. So this is one example where maybe a poor aspects and a large core might have still benefited with an endovascular treatment. So we look at another limitation for IV thrombolysis. This is a 60-year-old who underwent knee replacement, and while in the hospital she developed a stroke, a right MCI infarct. So whenever you find an acute ischemic stroke, we have to look at three things on MRI. The first thing is you have to look at the diffusion and flare mismatch. The second thing is you have to look for flare vessel hyperintensities. And the third thing is if it is a large vessel occlusion. The patient had all the three. All the three indicates the endovascular treatment should be done, and endovascular treatment is going to be beneficial in these cases. She has a large vessel occlusion with an NIHS of 14, but in this case she had underwent a recent surgery. Of course, it was a knee resurgery, but we still avoided IV thrombolysis, and we took her to cath lab for a direct thrombectomy. So this was the images while in the cath lab. The right MC is occluded, and we did a thrombectomy. We could capture the clot, and most of the procedures we try to do it as an awake procedure, as a conscious sedation. So she had a good recanalization. The post-op CT was good, and with a few weeks of rehab, she became independent. So in this case, we can see that IV thrombolysis, not giving IV thrombolysis and directly proceeding for endovascular treatment is equally good. So another example of a 60-year-old diabetic, she had underlying chronic ILD and she had domiciliary oxygen therapy. She presented with left hemiparesis of 5-hour duration. This was her the CT of lungs that was pretty bad, and this was the MRI that showed the right MCA territory infarct. The right MCA got occluded. She had NIHS of 9 at the time of presentation. No IV thrombolysis was done as she was beyond the time window, and she was shifted to the cath lab. So while in the cath lab, we had a difficulty. She was unable to lie down flat. So we had to keep her head up. We had to keep her propped up. She was orthopnic, and the second limitation was that we couldn't even give her sedation, and this was done completely under local anesthesia and a completely awake procedure. This was her intra-op images. There was heavy respiratory excursions. The movement of the catheters and the positioning of the head was difficult. She kept tossing and turning. We had to manage somehow. We could take our catheters up and we could finish the thrombectomy as quickly as possible. And it was a successful procedure and we could get a complete recanalization. The post-op CT was good and this was her clinical recovery. She made a remarkable clinical recovery and she could be discharged soon. We look at another example of a 50-year-old diabetic and smoker who had right hemiparesis and aphasia. 6 hours time window and NIHS of 12. We could see the left ICA is occluded and the left MCA is also not clearly seen. But there is a significant diffusion and flare mismatch, and apart from that we find hyperintense vessels in the left MCA. So all these are markers for good improvement with endovascular treatment. This DSA, that was a complete occlusion of the left ICA. We did a thrombectomy. In this case, there is complete occlusion of the supraclinoid ICA. It is a T type of occlusion. As there was an underlying stenotic lesion, we had to do balloon angioplasty and we could get a good recanalization. So this is one case where we had a T occlusion. The T and the L type of occlusions are based on the morphology of the type of occlusion and the thrombus. T type of occlusions, they usually have a higher mortality. Only with best medical management or IV thrombolysis, the treatment is, the mortality and morbidity is going to be very high. Only an endovascular treatment can improve the outcomes in a T type of occlusion. And as we have seen that in this patient, there was an underlying ICAD. There was this underlying stenotic lesion. In the Indian population, the ICAD is very common. And the presentation of ICAD-related LVO is slightly different, those with an embolic occlusion. The ICAD-related LVO, they usually present with fluctuating symptoms. There will be a slow progression and they will be having an underlying, they will be having a collateral circulation. The type of infarcts are usually in the watershed territory or in the border zone territory. These underlying ICAD, they have a higher rate of reocclusion. Even with endovascular treatment, they tend to occlude even while doing the procedure. So managing these, we need alternative antiplatelet therapies like tirofiban. And even in certain cases, we have to consider putting in a rescue stenting. But doing a rescue stenting in acute ischemic stroke has its own challenges, like we might have like hemorrhagic transformations, perforator occlusion and all such. So managing ICAD-related LVOs has to be done very carefully. A careful angioplasty should be done, and then maybe I can give intra-arterial tirofiban. And the main idea is to achieve adequate perfusion and not a complete angiographic result. Overzealous procedures, they all tend to have bad complications. This is the algorithm that we follow in ICAD-related LVOs. The suspicion comes when there is the type of infarct is like in the watershed territory, if there are slow progressors. And if there is a pre-treatment strategy, like if there is a facilities available for doing a direct thrombectomy, IV thrombolysis can be avoided and loading the patient with antiplatelets can be considered. But this is not often possible. So we still go for IV thrombolysis and we avoid antiplatelets. And when we decide using GP protein inhibitors like tirofiban in the cath lab. So we do stent retriever with stent retrievers or balloon angioplasty or with aspiration catheters. Tirofiban can be considered as they have a higher reocclusion rates. Usually we wait for a few minutes to see if there is any reocclusion. We can consider putting in a stent if the vessel is completely getting occluded. But putting in a stent in an acute ischemic stroke is a challenging issue. It can carry a higher risk of hemorrhagic transformation. We look at another example of a 40-year-old smoker who came with right hemiparesis. He was seen collapsed on the road and he was helped by the bystanders. At the time of presentation, he had hypotension and very poor GCS, so he was intubated, resuscitated. Then shifted for an MRI that showed a large infarct in the left MCA territory. He was shifted to the cath lab for a mechanical thrombectomy procedure. We could see that the ICA was occluded, and in the ICA there was a large floating thrombus extending from the cervical ICA. This was a large floating thrombus. A thrombectomy was done and all the thrombus could be removed. Persistent occlusion of the MCA, and even the MCA could be recanalized, and we could get a complete recanalization. At least angiographically, he had a complete recanalization, but there was progression of the infarct with a hemorrhagic transformation, and he had to undergo decompression. So what was the challenge here was the hypotension at the time of admission. The BP management was already discussed, but we have to see that hypotension should be avoided at any time in managing an acute ischemic stroke. Hypotension tends to worsen the outcomes, and it causes collateral failure and progression of stroke. This is a 17-year-old engineering student who came with speech disturbances and right hemiparesis. He came in 2 hours of time window. So this was the time, this was his MRI that showed an infarct. And the left MCA was occluded. So what do you do in a 70-year-old patient? The guidelines are usually for the more than 18 years, but in 17 years, especially in the 6 to 17 years group, endovascular treatment is considered a level 2, and we can still go for endovascular treatment in a 17-year-old. So we did a thrombectomy, we could get a complete recanalization, and his MIS soon improved to 4 by 20. So what was the cause of stroke in this case? He had a vegetation in the aortic wall. There was a healed vegetation in the aortic wall. So he later underwent aortic wall replacement. This was his follow-up MRI, and he was doing absolutely fine. Then another 83-year-old, this is another age extreme, 83-year-old with dysarthria and left hemiparesis, complete occlusion of the right ICA. What we do in advanced age, even if there is 80-year-old, IV thrombolysis can be still considered, and endovascular treatments can be still done even with advanced age. In this case, we found there was a severe underlying tight stenosis in the left cervical ICA, in the right ICA, and there was a occlusion of the right MCA M1. We call this as a tandem occlusion. In this tandem occlusion, we initially clear the stenosis in the cervical ICA first by doing balloon angioplasty, and then do the thrombectomy for the distal occlusion. So these tandem occlusions, some people even consider putting a stent in the acute scenario, but acute stenting, we preferably avoid that. So he had underwent a good successful thrombectomy, and he had a good recovery soon. So this is another example of a 45-year-old smoker who came with hemiplegia and NIHS of 18. He had a left ICA occlusion, and in this MRI we could see these are prominent deep medullary veins. So what does these deep medullary veins carry significance? We'll soon find it out. He underwent thrombectomy, but in this case the thrombectomy was a difficult one. There was thrombus fragmentation, migration, and multiple attempts had to be made to achieve recanalization. But at the end there was an incomplete recanalization. It was only a TK2A. Soon we found that he had hemorrhagic transformation, and he had to undergo a decompression. So hemorrhagic transformation sometimes happen after mechanical thrombectomy, and when we find these deep medullary veins on MRI, they indicate a poor outcome. They indicate the venous outflows are getting occluded, and there is reduced cerebral blood flow. So even after mechanical thrombectomy, you can have intracranial hemorrhage. And who are at a higher risk of having an intracranial hemorrhage after thrombectomy? Those who have inadequate recanalization, those who have multiple passes during procedure, those with a late window period, those with a higher NIHS, poor blood sugar, and poor collaterals. Using IVT does not increase the ICH after endovascular treatment. The ICH usually happens due to leaky blood-brain barriers. This is a 79-year-old. He was a general practitioner by himself. He had the right hemiparesis and aphasia. The MRI showed complete occlusion of the left ICA and MCA, infarcts in the left MCA territory. And the three things that we often look in MRI is the flare mismatch, flare hyperintensities. And apart from that, in this case, we had a clinical and radiological mismatch. The infarct was very small, but this NIHS was very high. So all these indicates a large vessel occlusion with good collaterals. And all these indicates endovascular treatment is going to be beneficial. He was shifted to the cath lab. And we did a DSA, and at the DSA, initially the ICA was occluded. And the left MCA had very poor collaterals from the pile supply. So it was decided to do a thrombectomy, but as the patient himself was a doctor, there were many patients involved in his management. It was decided that he should be shifted to a CT first, as before doing a thrombectomy. CT did not show any hemorrhagic transformations from IVT, so a thrombectomy was carried out. So when we brought him back to the cath lab, we could see that the ICA could be recanalized. So IV thrombolysis was helpful in him, that the ICA could be recanalized, but the MCA was still occluded. So we finished the thrombectomy of this, the occlusion of the left MCA with a balloon angioplasty and clot aspiration. He could get a good recanalization, and soon he started to improve. NIHS improved to 4. The follow-up MRI was stable. No progression of the infarct and recanalization of the vessels. This would be the last case. This is a 55-year-old who suddenly collapsed at his residence and became stuporous. So he was brought on a stretcher to the emergency department. MRI showed infarcts in the bilateral cerebelli, thalamus, and midbrain. There was a diffusion and flare mismatch along with hyperintense basilar artery. His sensorium gradually worsened and he had to be intubated. So he was shifted to the cath lab. There was occlusion of the basilar artery. So we had to do a thrombectomy of the basilar artery. We did it through a radial access and we could get a complete recanalization. So after the thrombectomy, he was shifted back to the ICU and he gradually improved. The CT was normal and he would be gradually weaned off ventilator. This was his recovery at day 7. So this was the only one lucky person that I know that who had a basilar occlusion and he could walk back home on his own. So the success rates and complications rates of EVT, they are variable. The success rates vary from 50 to 60% in multiple centers. Complication rates are up to 10%, like ICH, having vessel injuries, having vasospasm during manipulation. But all in all, endovascular treatment is a paradigm shift in managing acute LVOs. Every decision has to be made by tailor-made management and individualized multidisciplinary team. So, thank you.
Now the session is open for question and answers.
Good morning, sir. Thanks for the excellent talk. Sir, I have one query. So, if a patient presents with acute stroke and he presented within the window and his MRI is showing a large vessel occlusion, if the interventional neurologist is readily available, do you still prefer to thrombolyze and do thrombectomy or thrombectomy alone?
We will shift to the cath lab. We take a decision right in the cath lab table. If it is an underlying ICAD, we avoid IV thrombolysis and give tiropivan and do a thrombectomy.
Thank you, sir.
Thank you, sir, for that insightful session on pushing the boundaries of stroke care. Now I welcome Dr. Vardhan, sir, to kindly present a memento to Dr. Sudhir Chakravarti, sir, as token of our gratitude.
Before we proceed further, we move to the lamp lighting ceremony, symbolizing the pursuit of knowledge and removal of ignorance. I request our esteemed dignitaries to come forward. Dr. Vardhan sir, Dr. Gopalam Shivanarayana sir, Dr. Keshav sir, APMC Observer, Dr. Vamshi Krishna sir, General Secretary, Amaravati Association of Neuroscientists, Dr. Jalil sir, Dr. Arna ma'am, Dr. Lakshmi Lavanya ma'am, and Sunil sir are blessed ahead. Music. May this light guide us towards clarity, knowledge, and better patient care. Now I invite Dr. Keshav Rao sir, APMC Observer, to speak a few words about the CME. Next is next.
Good morning. I am Dr. Kesara Babu, APMC CME Committee Chairman. So I just want to say a few words because sometimes we are getting some problems because in the registration form, many people are not mentioning properly their email address. And if email address is not in clear words, perhaps the credit hours may not be allotted to you. And one more thing is, there is a registration number which many people are not writing properly. You know, for every registration number, most of the times there is a prefix. For example, my registration number is 9313. If I write 9313, my credit hours will not be allotted. So I have to write my full registration number as, my registration number is AMC 9313. So that is how we have to write, otherwise the credit hours will not be allotted. And all of you know very well now, recently, the APMC, after taking over ourselves on April 1st of last year, we have modified the CME rules regarding the credit hours. So up to 65 years, every doctor who comes for renewal of the registration has to submit 30 credit hours. And nowadays we have changed it like this: up to 65 years, everybody has to get 30 credit hours. Between 65 to 70, if you get 15 credit hours, it is okay. And 70, 80, above 70 and below 80, you need to get 10 credit hours for the renewal of the registration. After 80 hours, you don't need to submit any credit hours. So this is the latest schedule. And one more thing is, suppose if you have 30 credit hours in 1 year, this year, but all those credit hours will not be calculated. So every year you have to get 6 credit hours. And the idea of the credit hours is to introduce the latest knowledge of the science, which has changed so much in the recent times, both in the etiology and pathology and procedures and treatment-wise therapeutic procedures. So unless everybody is well acquainted with the latest methodologies, we have to put a blank face in the front of the patients. So this is the idea of the CMEs. So please utilize the CMEs. And thank you very much for giving me this opportunity to Kamineni Hospital. Thank you very much.
Thank you, sir. From vascular urgency, we move to one of the most critical neurological emergencies, brain herniation syndromes. Now I invite Dr. Jalil sir to deliver this session. Sir did his MBBS from Usmania Medical College, MS General Surgery, MCH Neurosurgery from prestigious Nizam's Institute of Medical Sciences, and received Best Resident Award from Nizam's Institute of Medical Sciences.
Pointer. ఇక్కడ నుంచి చేసుకుంటాను, అక్కడ నుంచి చేసి కానీ ఇదా అవును సార్ ఇది ఓకే నెక్స్ట్ ప్రీవియస్ సార్ ఓకే దిస్ వన్ నెక్స్ట్ సార్. Good morning. First of all, I'd like to thank Dr. Sridhar Narayan and the members of the organizing committee who have invited me to give this lecture. This is a basically basic lecture, and coming to Kamineni, Vijayawada is a very happy thing, because I have been working in Kamineni, Elbinagar since 1998. It's about 28 years since I've been working in Kamineni, Elbinagar. And I feel very happy and honored to have Dr. Gopalam Shivanarayan, who is one of the member in this conference. He has been my senior while I was in NIMS. He was a senior resident when I was a junior resident. And I learned a lot of things from him. Thank you. I will start off with my topic. I will be talking basically is a basic topic, the raised intracranial tensions and the cerebral herniation syndrome. See, we all neurologists and neurosurgeons are always tensed up with whatever may be the reason, raise ICP, whether it's a stroke, whether it's a trauma, or what is a tumor, or whether it's hydrocephalus. The patients, whenever they present with raised intracranial tension, our basic treatment is directed towards the decreasing the raised ICP. What is the intracranial pressure? ICP, see, it is just like a blood pressure. See, when we think of blood pressure, it is the pressure exerted by the blood column against the vessel wall. It is similar to that. The ICP is the pressure exerted by the brain, CSF, and the blood. That is the basic intracranial contents onto the cranial vault. So the normal range of ICP is 7 to 15. So many books say 5 to 15. Some people say 10. But in general, average less than 15 is taken as the normal ICP. Before we start off, we all should know what is the Monro-Kelly hypothesis. See, Monro-Kelly hypothesis is the intracranial compartment is incompressible. And the intracranial constituents like brain, blood, and CSF are in a fixed volume. And if there is increase in any one of the component, there must be some methodology by which the ICP is decreased. That is, either the CSF is pushed out, or there is an increase in the venous return becomes more, or the vascular supply becomes less into the brain. So whenever these things happen, to one particular level, say there is an increase in intracranial volume, the ICP is maintained till one particular level by various modalities. But at one particular stage, it gives off. And there is a rapid rise in the intracranial pressure leading to the brain herniations. See, this is a diagram which shows basically anyhow, the first photo shows, say there is a tube which has the arterial blood, venous blood, the brain parenchyma, and the CSF. So whenever the normal intracranial pressure is maintained, everything is intact. There are two taps. One is draining the CSF, the other is draining the venous blood. So whenever there is an increase in the ICP, what happens is, I don't know why I'm not able to. See, whenever there is an increased ICP, the first thing that happens is the taps open. That is, the CSF gets drained, and also there is an increase in the venous blood flow. So the ICP is maintained. But whenever the intracranial volume increases, either due to edema or hemorrhage or due to tumors, in spite of this CSF getting drained or the increase in the venous outflow, there is a rapid increase in the ICP. So how do we measure intracranial pressures? There are two modalities. One is the invasive, the other thing is the non-invasive methods. The invasive method is first is placing a intraventricular catheter. This will help in recording the ICP, and at the same time, we can drain the CSF by reduce ICP whenever there is an increase in ICP. The one that we use commonly is the intraparenchymal monitor, where microsensors are placed in the brain parenchyma, and we record the ICP on a monitor, just as we monitor the ECG. So whenever there is an increase in ICP, we can give an extra dose of mannitol or some other modalities so that in order to decrease the intracranial pressure. Then third is the lumbar puncture, is basically a snapshot measurement of opening pressure recorded in the spinal canal, but it do not show a continuous ICP monitoring. Then the non-invasive monitorings are, one is by the fundoscopy, which will show the amount of the degree of papilledema. The other thing that is now done bedside, especially with the help of the critical care doctors and we neurosurgeons as well as the radiologists, is the measurement of the optic nerve sheath diameter. The optic nerve sheath diameter up to 5.5 is treated as normal. Whenever it becomes more than 5.5, it means that the patient is having an intracranial measure and we have to take some corrective action. And then we also do the transcranial Dopplers, which can be done in the ICUs while the patient is on monitors. And what we do is we measure at the pulsatility index. See, this pulsatility index is usually done at the time in patients, especially it is used much more in the by the gynecologist to monitor the fetus, where we look at the uterine vessels. Similar thing we can do in the brain, where we can monitor the blood flow at the middle cerebral artery, by which we can record the patient whether he has got an ICP. Coming to the intracranial hypertension, normally, as I said, is about 5 to 15, but some of the books say in general 10. But what is everyone says clearly is, when do we say the patient has got a raised ICP, which can be broadly divided into mild, moderate, or severe. Mild ICP is one when the pressure is between 20 to 29, moderate is between 30 to 40, and severe is more than 40. What are the features of ICP? Usually the present with headache. Headache is usually more in the mornings, it is throbbing in nature, and is progressively increasing in severity. The headache is because it is usually aggravated by coughing, sneezing, or bending over, and is due to the mechanical traction of the pain-sensitive dural membranes and the large intracranial vessels innervated by the trigeminal. See, many of the people say the patients with raised ICP have headache, severe headache in the mornings. Do we know why? Because during sleep, most of the time we are supine, and we also retain carbon dioxide levels in the body. This increase in carbon dioxide levels causes vasodilatation of the vessels and can lead to ICP. And again, the venous drainage is much less when we are in the supine position rather than the sitting or the standing position. So less of venous drainage also causes increase in the ICP. So that is the reason the patients may get up with severe headache in the mornings in the patients when having intracranial pressure. The second is that we come across vomitings. See, vomitings are because of direct stimulation of the area of prostoма or the chemo-CTZ zone, which is located at the floor of the fourth ventricle. What is classically described, the vomitings are known as projectile vomitings. What we mean by projectile vomiting is the patient does not have an associated nausea. Because CTZ gets stimulated, the patients have vomitings without any nausea. And then, of course, the patient may have other neurological symptoms in the form of irritability, confusions, or altered mental states. And some of these patients may present with diplopia or blood of vision because of either papilledema or because of the isolated six-nerve pulse. Of course, the signs of papilledema, the patient may have focal or no neurodeficits. Then again, what is very important is, in the patients, we should all know about the Cushing's triad, which consists of hypertension, respiratory irregularity, and bradycardia. See, again, when we talk about this Cushing's triad in the case of ICP, what we should know is, why do the patient have bradycardia in the patients with ICP? See, whenever there is an increase in ICP, in order to maintain the cerebral perfusion measure, there is hypertension. So when the hypertension becomes more, we have got the receptors at the aortic vessels and the larger vessels, and these baroreceptors get stimulated, and the baroreceptors cause parasympathetic increased activity leading to bradycardia. So that is the reason why we have got bradycardia in the patients with raised ICP, and whenever we have got bradycardia, it looks like an ominous sign that the patient has got a rapid, very high ICP, and he may herniate any time. Of course, in infants, we can see a bulging fontanelle, irritability, or high-pitch cry or separation of the cranial sutures. See, what is cerebral perfusion pressure? It is the pressure gradient driving the blood flow into the brain. It is vital for ensuring adequate cerebral blood flow, which supports the metabolic demand. See, cerebral perfusion pressure is basically a mean arterial pressure minus the ICP. And mean arterial pressure we should all know, because especially the youngsters, they hardly know what MAP is. Basically, I would like to say MAP is the diastolic pressure, which is 1/3 of the pulse pressure. And pulse pressure is the difference between the systolic and the diastolic pressure. So whenever we calculate the cerebral perfusion pressure, we should know the mean arterial pressure and the ICP. Normal CPP is about 70 to 80, and whenever there is a increase in ICP, there leads to decrease in the cerebral perfusion pressure, threatening cerebral perfusion. Then these are the ways the cerebral blood flow gets regulated. One is autoregulation occurs by the pressure regulation or the metabolic regulation. What it means is the brain keeps the cerebral blood flow constant via autoregulation when the cerebral perfusion pressure is between 50 to 150. Beyond these limits, or when there is acute brain insult, this autoregulation gets disturbed. And when the cerebral perfusion drops below this range, there is a cerebral ischemia and causing damage to the brain parenchyma. The other things are the metabolic parameters. What is important is the PaO2 levels and the PCO2 levels. Normal PaO2 levels is between 80 to 100, and cerebral blood flow is stable until the PaO2 levels fall below 50. Similarly, this is wrong. PaCO2 levels are normally between 35 to 45. It is not 454. Sorry for the wrong slide. And PaCO2 levels are a very potent indicators, and the changes in the CSF and the cerebral flow changes by 3% for every 1 millimeter change in the PaCO2 levels. Now coming to the main topic, brain herniations. See, basically we all know what a hernia is. See, normal, any hernia, for example, inguinal hernia, femoral hernia, diaphragmatic hernia, see, there is herniation of the normal tissues through a opening. Through a normal opening, these normal tissues go through, or herniate through that. Similarly, in the brain, what we have got is acquired intracranial herniations, wherein either brain, tissue, blood, or the CSF shifts from the normal position through an opening or through a defects or through some of the membrane defects into the some other area. These are basically known as the brain herniation. And whenever the patient has got a brain herniation, it requires medical emergency and requires immediate medical attention. Of course, cerebral herniations can be caused by a number of factors, like basically all this lead to rapid increase in ICP causing the brain herniation, which can be trauma, cerebral hematoma, intracranial hematomas, edema, strokes, tumors, or infections. What are the types of brain herniations? One is the subfalcine herniation or the cingulate herniation. Second is the central herniation, that is the tentorial herniations. Then the uncal herniation, which is again the tentorial herniation. Then these things, ascending tentorial herniation, we are seeing lesser now, which used to be seen much more common earlier. I will just go into the details subsequently. Then the tonsillar herniations, we are all aware. Transcalvarial herniations, which are basically extracranial. And what is the other thing is transalar herniation, which some of you may not have heard. This diagram shows the basically different type of herniations. One is the extracranial herniation, which are seeing the brain herniating through the skull wall defect. Then this is the, I'm not able to get a pointer. This is the subfalcine herniation. Then below is the central descending tentorial herniation. Then the lateral DTH means lateral descending tentorial herniation and the tonsillar herniations. And the slide on the other side, the photo on the other shows the ascending tentorial herniation and then the tonsillar herniation. What is the cingulate herniation or subfalcine herniations? These are mostly seen in the supratentorial tumors where or any bleeds which are in the frontal, temporal, or the parietal lobe, wherein the cingulate gyrus pushes under the falx cerebri to the opposite side. Usually it does not have major presentations, but sometimes, though they have headache, the patients may present with, because the cingulate gyrus presses the anterocerebral artery, and the patient may present with contralateral leg weakness. However, when it becomes much more, or there is a rapid subfalcine herniation, both the anterocerebral arteries can get compressed. And the patient, in fact, may present with both lower limb weakness, like a case of paraparesis. So one should be aware, in cingulate herniation or the subfalcine herniations, the patients may present with raised ICP with paraparesis. This is a diagram. This is a slide which shows the slide on the left side to me shows the cingulate gyrus herniating below the falx. Can I show here? The arrow shows that. Now coming to central herniations are basically tentorial herniations. This can be descending central transtentorial herniation, wherein there is a displacement of the diencephalon, that is the thalamus and the hypothalamus and the temporal lobe. They herniate through the tentorial notch. This subsequently leads to compression of the brainstem, especially the midbrain and the pons, and leading to impaired blood flow, leading to brainstem dysfunction and secondary hemorrhages. The photographs on the left side shows the central descending tentorial herniations. See, this is an autopsy picture of the brainstem, which shows multiple small hemorrhages within the midbrain. Basically, these are durate hemorrhages which happen secondary to the intracranial bleed. Coming to the imaging features of descending transtentorial herniations, there will be downward displacement of the brainstem structures, compresses the ventricle, and there may be midline shift when it is basically on one side. Central descending transtentorial herniation, there are 5 stages. First is the early diencephalic stage. Second is the late diencephalic stage. Third is the midbrain upper pons stage. Fourth is the lower pons or the medullary stage and the medullary stage. See, these stages are very important because if you are able to operate, pick it up and do surgeries and manage immediately, when up to 3rd stage, we will be able to salvage the patients. However, if the patient goes into 4th stage, it is very difficult to salvage the patient, and stage 5, there is no role of any surgical, even if the patient got features of resizing. In the early diencephalic stage, the patient starts having a decreasing level of sensorium, and he has got agitation, difficulty in concentration, and drowsiness. Pupils at this stage are small and reactive, but there is a cerebrospinal reflex is present, and then the dorsal movements are positive, and the plantar reflex are flexor. The patient will be having extra sighing or yawning. This is the first stage. In the next stage, this is just a diagram showing what all I have told you. This is a late diencephalic stage, wherein the diencephalic impairment is thought to be the result of stretching of the small penetrating vessels of the posterior cerebellar and commeric arteries, which supplies the hypothalamus and the thalamus. In this phase, the patient is much more drowsier, and there is no localizing response. Initially, he's got a localizing response where he pushes with the hand. Here, he's got a withdrawal. And at this stage, he will start having a decorticate posturing, and again, he'll be sighing or the yawning. This is again the photograph, which shows the same structures. Next is the midbrain or upper pons stage, where the motor tone is increased. At this stage, the patient will start having the decerebrate posturing, and he will be hyperventilating. Pupils are irregular and fixed in position, but dorsal movements may be difficult to elicit, but sometimes we will be able to elicit, we may not be able to elicit. It indicates is almost irreversible ischemia, and therefore intervention is a must before this stage to save the patient. These are lower pons at the medullary stage, wherein there is no spontaneous activity. Of course, the spinal reflexes are written absent. Spinal reflexes may be present because now they are at the level of the spine, they are nothing connected with the intracranial structures. And the dorsal movements are absent, pupils are dilated and fixed, and the patient will start having ataxic respirations. This is the last stage or the medullary stage, wherein there is total, it's almost like a pre-death stage where the limbs become totally flaccid. There are no pupillar responses, there are no ocular movements, the respirations are slow, irregular, and ultimately lead to death. After having gone through this is the central tentorial, descending tentorial herniations. We'll talk about the uncal herniations, which is otherwise known as lateral descending tentorial herniation. Where is the uncus? Usually seen in the patients where there is a temporal lobe lesions and a parietal lobe lesions, usually unilateral lesions. Here in the medial temporal lobe or the uncus, shift downwards into the posterior fossa through the tentorial notch. During this stage, it pushes the first thing that gets compressed is the third nerve. So in these patients where there is a hemispheric lesions, what we look at, because the third nerve gets involved, we look at the pupils. The first thing that happens is the pupils which gets dilated on the ipsilateral side of the lesion. So as it becomes more, it starts pressing the cerebral peduncles. I'll just show. And then the patients will have ipsilateral, there is a contralateral hemiparesis due to the pressing of the ipsilateral cerebral peduncles. But however, when the compression is rapid, it starts pushing the opposite side. The midbrain gets compressed to the opposite side, and the patient may present with ipsilateral hemiparesis. So what is important is not the hemiparesis when the patient is deteriorating, but look at the pupils. Pupils is much more collaborative rather than the hemiparesis. Then these herniations are otherwise known as earlier we have talked of the descending herniations. This is the ascending transcensory herniation, which we see in the patients basically who have got the posterior fossa tumors or the large posterior fossa bleeds where the brainstem herniates or the vermis herniates into the supratentorial compartment. See, this we are not seeing much, but earlier we used to see more because patients who used to have a posterior fossa lesions used to have an associated hydrocephalus. So in order to decrease the ICP, what we used to do earlier is we used to go for do a shunt, or you used to put a EVD and subsequently take up the patient for surgery. The moment we do a shunt and shift the patient to the recovery part, the patient used to deteriorate. This was because there is a rapid decrease in the supratentorial compartment. ICP would decrease. So the posterior fossa structures, they will push pressure on the vermis and it will herniate up into the supratentorial compartment to the tentorial notch. Here in the MRI, we get a classical finding because these things go and push the midbrain, leading the flattening of the quadrigeminal system. And what is important to see on the MRI is the spinning top midbrain. The midbrain looks as if the top which we are spinning, the way it spins, that's the way the picture looks on the MRI. These are the other herniations which again see in the posterior fossa tumors. When there is large posterior fossa tumors, slowly the tonsils will herniate through the foramen magnum, causing compression on the medulla, and the patient may lead to lower cranial palsies and may die immediately. We may not get much time. See, but what we should know is, many a time when we talk about the tonsillar herniations in the posterior fossa, we should be aware of an entity. If we should be aware actually in the first MRI or first scan, we should be able to see at what level the tonsils are. So subsequently when we do a CT or the MRI, we should be able to pick up the tonsillar herniations. These tonsillar herniations can be seen normally in the patients with the congenital, like Arnold-Chiari malformations may having some amount of tonsillar herniation. This is one of the DD, which is a normal variant. See, in the Chiari malformations, the cerebellar tonsils can go in type 1, can go below the level of the foramen magnum. In type 2, there is a displacement of the brainstem, and the patient is fully conscious along with the tonsils. And type 3, there is a displacement of the cerebellum and the brainstem into the high cervical meningocele, and there may be a cerebellar hyperplasia type 4, which is basically not an herniation, which is a normal variant. But here what is very important is, normally in any of the persons, there can be a tonsils up to 5 millimeters below the level of the foramen magnum. So when the tonsils go beyond this only, we talk about cerebellar tonsillar herniation. See, this is a transcalvarial herniation, which has basically extracranial herniations, which now we see in patients following the decompressive craniotomies, wherein the brain tissue comes through an opening in the skull. Usually we see following a craniotomy when the ICP is very much elevated. But however, that is the reason why in children or infants, when they have got a linear fracture skull, we should follow with either the CT scan or clinical examination, because there can be a growing skull fractures wherein the brain herniate can through the defects or the fracture site and start separating the suture line and can herniate. So this is basically following a craniotomy. The other thing is you have to look out for in infants for a growing skull fracture. Coming to the types of transcalvarial herniations, as I said, immediately following trauma or for surgery, there is acute. However, there can be chronic. Initially, when we do a craniotomy, there is a small bulge. But as the time passes by, because of venous congestion, this bulge can become more and more. So the herniation can become more over a period of time. And then this is entity when sometimes we are seeing more often, that is known as the paradoxical herniation, wherein rather the brain herniating outside the skull, the brain will herniating within the skull. It's getting separated from the skull and goes inside and inside. This happens, otherwise known as the sunken scalp syndrome, where following a surgery, there is a rapid decrease in the intracranial pressure, and hence because of the atmospheric pressure, the brain will get separated from skull and goes inside and inside. See, I just show this. The one on the left shows the brain coming out through the calvarium. Again, the same thing that we see on the right side. This is an entity which is known as transalar herniations, which has coming
how do you define drug-resistant epilepsy? So failure of more than two or more than two appropriate anti-seizure medications which are given with adequate dose and duration, whether monotherapy or in combination. Then if we can't achieve seizure freedom, then it is called as drug-resistant epilepsy. So nearly 30% of the patients develop drug-resistant epilepsy, leading to high morbidity and mortality, and also impairment of quality of life. So what are the risk factors of drug-resistant epilepsy? So lack of response to first anti-seizure medication, high seizure frequency, epilepsy syndromes, neurological deficits, abnormal EEG findings, younger age at epilepsy onset, and multiple seizure types with longer duration of epilepsy are all the risk factors of drug-resistant epilepsy, out of which lack of response to first anti-seizure medication is very important one. Before we confirm it as true drug resistance, always rule out pseudo-resistance. That is, there might be unresponsive to anti-seizure medications because of diagnostic errors. So we might be misdiagnosing reactive epileptic seizures or non-epileptic seizures like syncope, paroxysmal dyskinesia, etc. Or there can be misclassified seizures due to structural brain lesion. Or there can be therapeutic errors in the form of subtherapeutic doses of drugs or wrong selection of drugs. So, and third thing is there are low serum anti-seizure medication levels, although we give the adequate doses, but serum levels will be low. Third thing is poor compliance. This is very important because in India, in current trend, poor compliance is a major factor where there is drug resistance pattern is noted. So low serum anti-seizure medications are the first cause of pseudo-resistance, whereas inadequate choice of drugs or dosage is the second point. So appropriate dosage of drug is very, very important in this scenario. So whenever you see a case of drug-resistant epilepsy, always go for further testing like video EEG monitoring, interictal EEG, MRI brain epilepsy protocol. If we can't identify the epileptogenic focus, you go for PET, SPECT or MSI. So video EEG monitoring is the gold standard to rule out seizure mimics. So second thing is we have to confirm the epilepsy diagnosis, and also we should identify that any epilepsy syndrome is there. So what are the mechanisms of drug resistance in epilepsy? So one is the drug is not getting transported to the epileptogenic focus. So why? Because there is efflux of anti-seizure medications at the blood-brain barrier level. Second is there might be drug target is altered because the ion channels where drug is binding is altered or down-regulated. Third is neural network changes, like in chronic epilepsy, there will be synaptic reorganization leading to drug resistance. Fourth and very advanced topic is neuroinflammation, which will be discussed later. And then fifth is genetic factors. So there is a epigenetic modification of mTOR pathway leading to sodium channel alterations or any channel alterations. Sixth is disease severity. So early onset structural lesions or severe EEG changes leads to refractoriness. So multiple mechanisms leads to the multiple mechanisms for drug-resistant epilepsy. So there is a need of polytherapy and precision medicine. So these are the mechanisms of drug resistance, and then so genetic and acquired factors leads to altered targets plus drug transport, leading to reduced drug efficacy and persistent seizures. So why focus on pharmacotherapy? Because many are not surgical candidates, and we need a better drugs with precision medicine. So current pharmacotherapy mainly focuses on correct diagnosis, correct or appropriate drug selection, and adequate dosing. So these are all the anti-seizure medications. So sodium channel blockers are like, there are a list of sodium channel blockers, of which cenobamate is the newer one. Synaptovesical binding modulators like levetiracetam and brevactocitram, of which brevactocitram was a newer one. And then glutamate. So glutamate is one important thing causing drug resistance. So perampanel and phenobarbital are two important. Perampanel is a new drug modulating the glutamate, and then felbamate, valproate, and topiramate acts on NMDA receptors. So retigabine is one more newer drug which acts on potassium channels, and then you can see ganaxolone, which acts on postsynaptic GABA receptors. And coming to everolimus, which decrease mTOR pathway, cannabidiol, which acts on endocannabinoid system, and fenfluramine, which increases serotonergic pathway. These are all the newer drugs. So, brevacitram, it is a synaptovascular ligand modulator with better tolerability, and parampanel, which is a very important advance, which is AMPA receptor antagonist with better tolerability, and lacosamide, which enhances slow sodium channel inactivation, and eslicarbazine, which is similar to carbamazepine with better tolerability. Cannabidiol, which modulates endocannabinoid system, it is approved for Dravet syndrome and Lennox-Gastaut syndrome. So cenobamate, it has a dual mechanism which acts on GABA, which enhances GABA and also inhibits sodium channel. Fenfluramine, as we already discussed, has serotonergic mechanism and it is very much effective in genetic epilepsies. So what is the important thing is we have to combine, in the case of drug-resistant epilepsy, we have to combine the drugs in a different manner of different mechanisms. Suppose if there is a sodium channel blocker, we have to combine with GABAergic drugs or synaptovascular ligands so that there will be no toxicity but efficacy will be more. So second thing is always avoid enzyme inhibitor with inducer combinations, just like valproate is an enzyme inhibitor. So we shouldn't combine with strong enzyme inducing drugs like carbamazepine and phenytoin. So some examples like if valproate and lamotrigine. So valproate is enzyme inhibitor and lamotrigine and valproate inhibits lamotrigine metabolism so that in low therapeutic doses it will be very much effective. And second thing is for focal onset seizures, we generally introduce levetiracetam in the first scenario. Second thing is we can add lacosamide, which is very effective. And then for refractory focal epilepsy, especially in the case of brain tumor related gliomas, we combine levetiracetam with valproate. So, and then in Dravet syndrome, generally we start with valproate and clobazam, but stirpental is a recent advance, and these three are very effective in Dravet syndrome. And lamotrigine plus topiramate are also very effective in refractory patients. And then combining sodium channel blocker, that is lamotrigine with levetiracetam, also shows high values. And then we should also know what are the combinations to avoid. So lamotrigine plus carbamazepine, both are sodium channel blockers which have undesirable side effects. Second is, combining two sodium channel blockers should always increase the side effects without improving efficacy. So always avoid combining same mechanism drugs. Also in autoimmune associated epilepsy, avoid strong enzyme inducing drugs like carbamazepine and phenytoin as they interact with the immunotherapy. And for older adults, levetiracetam and lamotrigine are favored for their low side effect profile. So other combinations to avoid are like, especially in myoclonic jerks and juvenile myoclonic epilepsy, always avoid sodium channel blockers like carbamazepine, oxcarbamazepine, phenytoin and vigabatrin. And as Dravet syndrome is a sodium channel disorder, so sodium channel blockers are absolutely contraindicated. And also Lennox-Gastaut syndrome, we avoid carbamazepine, phenytoin and vigabatrin. So for Dravet syndrome, second line add-ons to the core regimen of valproate plus clobazam include stirpental, fenfluramine and cannabidiol. So this is the recent advance, disease modifying advances. That is, we just target the mechanism of anti-epileptogenesis, and we focus on the ATP causes, ATP inflames excessive inflammatory neuroinflammation and hyperexcitability. So we target on ATP influx. So third important mechanism is glutamate modulation. So glutamate, excessive glutamate in the synapse causes increased NMDA receptors, calcium influx, and AMPA receptors, fast excitatory transmission, leading to neuronal injury, hyperexcitability, and epileptogenesis. So what we target on is this AMPA receptor antagonist, that is perampanel, which is a non-competitive AMPA blocker, and it reduces excitatory transmission. And then next is NMDA. NMDA we target with memantine, ketamine, and in few selected cases. So glutamate release in presynaptically, we can do it with levetiracetam-like drugs. So we are more moving towards precision medicine rather than broad way. So fourth one is ion channel precision. So ion channels might be initially mutated from genetic things, or after later on acquired channelopathies, there can be a mutation in the ion channels. So instead of taking broad sodium channel blockers, we are targeting the specific sodium channels. So one of it is retigabin, which targets on potassium channels. So blood-brain barrier dysfunction, as we already discussed, blood-brain barrier dysfunction leads to albin influx, leading to inflammatory response, which spreads, causing neuronal damage. So we do anti-inflammatory therapies to restore the blood-brain barrier integrity. And also one more important mechanism is at blood-brain barrier, there will be efflux of drug because of P-glycoprotein upregulation. So efflux transporter inhibition can be a major challenge in drug resistance. So drug delivery innovations include nanoparticles, liposomal drug delivery, and focused ultrasound, which leads to blood-brain barrier opening. So these are the few more advances, like genetic specific therapies, targeting sodium channel in Dravet, and antisense oligonucleotide therapies, zonoverescin, and then cell-based regenerative therapies, where GABAergic intraneuron transplantation can be done. These are very upcoming things. So epileptogenesis prevention therapy. So there is a latent period between the brain insult and onset of epilepsy in the case of traumatic brain injury and stroke. So in these cases, we can include anti-inflammatory agents and mTOR inhibitors or neuroprotective drugs, so that latent period will be, we can capture the latent period and prevent the epileptogenesis concept. So coming to closed loop systems. So on-demand therapy. So whenever seizure is detected by intracranial signals, we can automatically deliver the drug in the case of these loop monitorings. So this is a closed loop systems. So what is the advantage closed loop system is, it is responsive neurostimulation system. So so that whenever we detect a seizure mechanism, immediately it delivers drug or cortical stimulation, so that systemic side effects of drugs will be lowered and it will be more personalized therapy. This is CRISPR-based gene editing, which is also an advance. So genetic targets like sodium channels or other channelopathies, the gene correction is to be done with vector delivery, leading to correction of the defects. So this is a personalized anti-seizure medication therapy, which is also AA based. So first of all, we collect all the patient data, like in the form of EEG, brain scans, and history of the patient, so that data processing will be done, leading to drug selection. What is the type of drug we have to select and what is the dosing, and also seizure forecasting prior to the seizure detection, leading to whenever we detect a seizure phenomenon, immediately the drug will be delivered in appropriate doses to the exact target. So neuromodulation, when we go for neuromodulation, so when it is a refractory epilepsy, and then there is no localization of epileptic focus, then we go for neuromodulation. So when there are bilateral or multiple focal areas of seizure onset, or eloquent cortex site of lesion, that is important cortex lesions where motor functions, language and visual functions are there, then we can't go for epilepsy surgery. There we can use this neuromodulation. So neuromodulation includes vagal nerve stimulation, which is approved for drug-resistant focal seizures in children and adults more than 12 years of age. So we identify the focus and few areas and then stimulate the cortex over there. Coming to deep brain stimulation, so we plant a subdural electrode and deep electrode, and we select epileptogenic areas, might be anterior nucleus of thalamus or hippocampus or few areas, but anterior nucleus of thalamus showed good results in the case of DBS. So it predicts the onset of seizures and immediately sends the electrophysiological signals and then notify the patient to start the DBS. So responsive cortical stimulation is also the same. And transcranial magnetic stimulation, which reduces cortical excitability, and trigeminal nerve stimulation, it is applied externally, may reduce seizures in patients with drug-resistant focal epilepsy. So ketogenic diet, there are 3 to 4 types of ketogenic diets, which are high-fat diets. Fat and protein ratios will be altered, or modified Atkins diet. Ketogenic diet we generally preferable in pediatric population, and enzyme defect epilepsies is much preferable, but also ketogenic diet is very much effective in drug-resistant epilepsies because it stabilizes the membrane and decreases hyperpolarization, and hence increase hyperpolarization and hence decrease the seizure processes and hence neuronal excitability, stopping the seizure process. So final summary, approach to case of drug-resistant epilepsy. So whenever a patient, we think it as drug-resistant epilepsy, always go for evaluation to rule out seizure mimics with video EEG and identify the seizure epilepsy syndrome and classify the epilepsy. And then third thing is rule out other seizure mimics, and then if epilepsy is confirmed, then if epilepsy is not, if there is non-epileptic condition identified, so treat accordingly. If epilepsy is confirmed, then always rule out pseudo-resistance by asking history about poor adherence, inappropriate anti-seizure medications, inappropriate doses, or intolerance of or any adverse side effects we have to check. If there is anti-seizure medications failure, then you again optimize the regimen with other anti-seizure medications. So if seizures are controlled, then we can continue with the anti-seizure medications. If seizures are not getting controlled, and if he had persistent impairment of consciousness, injuries, and increased seizure frequency, you have to take the patient for ablative procedures. If the patient is not the candidate for ablative procedures, then consider neuromodulation or ketogenic diet. And then also disease-modifying therapies comes here. So what are the key points of this topic are? So recognize drug-resistant epilepsy early. Any failure of 2 or more than 2 anti-seizure medications, we always have to refer early for further evaluation. Next is, so now epilepsy is from symptom control to disease modification. So it is more of etiology driven and mechanism based therapy. And then there are a lot of newer anti-seizure medications which have better efficacy and tolerability, like cenobamate, brivaracetam, perampanel. And also there should be a rational polytherapy in combining drugs, which will be very effective in dealing with the drug-resistant epilepsy. And there are emerging targets like neuroinflammation, glutamate toxicity, and blood-brain barrier dysfunction. And future therapies include gene therapy, ASOs, and CRISPR. So last but not least, do not delay surgery or neuromodulation. And then holistic care matters. So we have to always take into consideration about patient cognition, mood, and quality of life. Also, we have to properly ask the patient to adhere to the drugs. And though there are a lot of advances in epilepsy, always the appropriate selection of drug, appropriate dosage, and adherence with check on side effects is very, very important in any epilepsy management. Thank you.
Thank you. Now the session is open for questions. Thank you, ma'am, for such a practical and forward-looking approach to epilepsy care, ma'am. Now I welcome Dr. Gopal Shivanarayana, sir, to present memento to Dr. Lakshmi Priya, madam, as token of our gratitude. Start, sir.
ఇప్పుడు ఈ టాక్ ఉంది కదా ఈ టాక్ మీద చెప్తానికి regarding the refractory epilepsy. So out of my experience, what I say, monotherapy is the best therapy. Out of 34 years of experience, I come across only 2 cases of refractory epilepsy. Only 2. Because the reason being is most of the people are not trying the monotherapy. So you have to go increase the dose up to the maximum. Either the seizure has to be controlled or the patient has to develop the higher dose of the side effects of a anti-epileptic drug. This is a basic thing which we have to follow. The commonest drug, simplest things is the other thing, older drugs are the best things. And the believe the levetiracetam, now most of the people are using, and this is the drug which is the worst drug. Very highly costly and very inefficient, and mostly they will give you psychotic symptoms also. To avoid this, the company are coming forward with the brivaracetam and is giving a more worse psychiatric symptoms. But they're claiming that this is a very safer drug compared to the levetiracetam, and the charges cost is more than 3 times above the levetiracetam. So organized, legalized cheating is the business. And justifiable usage of wisdom is the profession. So, dear friends, you all the believe, and MBBS is not a simple this is not a degree. 3 years is a degree, 2 years is a post-graduation, and 1.5 year is the PhD. A person got a MBBS degree means they have the 3 degrees in hand. So first of all, we have to believe we are a postgraduate, postdoctoral courses certificate, we have the MBBS. MBBS is not the degree. The constellation of the degree and post-graduation, some of the part of the PhD. So this is the burden is very high in the poorer country, and people have to think when emotionally that we have the social factors very, very high with the seizures. So these are most of people believe that there are common general practitioners are there. My friends, I'm appealing to you. You try the monotherapy, the best therapy. And the older drugs are the very, very efficient drug. Out of the thing, my experience is the carbamazepine. And only thing we have genetically, we are some susceptible to the reaction. The Asian population, we have a specific gene is there. So that's why we have got more of a Steven Johnson's or drug reactions are there. Safer next is the oxcarbazepine. So people, this is my appeal. There's so much of lot of burden is there. We are conducting for last 26 years in 40 places. So this is my experience out of a seizure. So this is my appeal to the public and the general practitioners. Thank you.
Thank you, sir. Surgery is no longer the last resort in epilepsy. It is becoming a planned strategy. Now I invite Dr. Sridhar Narayana sir to enlighten all of us on epilepsy surgeries. Sir did his MBBS from AMC Visakhapatnam, MCH Neurosurgery from prestigious Nizam's Institute of Medical Sciences, Clinical Fellowship on Epilepsy Surgeries from University of Calgary, Canada, and sir received Kidlampudi Gold Medal as a Best Clinical Surgeon and organizer of Ashram Neurocon, National Neurosurgery Conference. Welcome, sir.
Good morning. A warm welcome to our CME today. Thank you for the warm introduction here. So, straight away jumping to our discussion today. So, as Sivanarayan sir aptly said, the drug resistance is not so common. If you see, since I'm a neurosurgeon standing in front of you, having experience with epilepsy surgery, probably the chance of a patient seeing me or me seeing a patient of epilepsy is 1%. It means, as a neurologist who see a lot of cases, if you see 100 cases, maybe one patient will come to me because of the drug resistance. So if the patient is resistant to a monotherapy, the chance of him being drug resistant for rest of the drugs is more than 70%. So monotherapy is the gold standard in epilepsy. So chance of him responding to a second drug will be maybe 10% or less than 20%. And evidence literature says if the person fails 2 drugs, then he being drug resistant, the chance of him being drug resistant is more than 90%. So monotherapy is the gold standard for epilepsy, and most of them do respond to monotherapy. So since our topic is like advances, epilepsy surgery is like a bit advanced treatment strategy for patients who don't respond to anti-epileptic medication. So let us start with a simple basic scenario. Like you see, I have given you 3 scenarios here. First scenario, there is a patient here, 30 years male. You can see there are 2 findings here. There is a cyst on the left side, a cortical cyst, and there is a finding on the MRI on the right side. There is a finding on the right side, and you can see easy. I have shown a basic broad line where you can see the majority of the ictal activity is present in the right mesial temporal. So this is the first scenario. So all these 3 patients are drug resistant. All these 3 patients are drug resistant. This is the first patient where there is some finding on MRI on both sides, but easy the findings are on the mesial temporal location on the right side. And look at the second scenario. There's a 44-year-old female, failed multiple drugs, anti-epileptic drugs. MRI, you can see MRI is normal. And you can see the EEG is mostly lateralized. May not be localizing to a particular area, but is lateralized to right side. But MRI is not showing any evidence. So what you will do in this scenario? Patient has already failed multiple drugs. Now look at the third patient. He is a pediatric patient. MRI is seemingly normal. You can see the EEG activities, diffuse, bilateral, generalized epilepsy. So what we will do in this scenario? So these scenarios you will commonly come across. Most of them, they respond to drugs. But here the scenarios, what we are discussing, they are purely drug-resistant epilepsy. I have shown you 3 scenarios. So what we will do? So maybe by the end of the discussion, we can come to some conclusion how to treat this kind of patients, right? So myself, I am Dr. Sridhar Narayana. I am a senior consultant neurosurgeon. I have done my fellowship in clinical fellowship in epilepsy surgery, both adult and pediatric epilepsy surgery from the University of Calgary, Canada, like some 8 years ago. And I've been practicing in Vijayawada for the past 8 years. So what is drug-resistant epilepsy? I think you had a full meals discussion from Dr. Lakshmi Priya just before me. So my presentation is just like a cherry on the top, a dessert that comes at the end of the meal. So drug-resistant epilepsy is typically defined like a broad definition, like a patient should be having persistent seizures even after 2 years of treatment with a neurologist. So please don't mind the neurologist term here, because in definition they use neurologists because neurologists treat epilepsy day in and day out, and they have vast experience with dealing with the side effects of anti-epileptic drugs and dosages. General medicine people, pediatrics, they all treat epilepsy, I agree. But neurologists, they have more experience in treating the side effect profile of the epileptic drugs. So in broad terms, in definition of drug-resistant epilepsy, They define like a neurologist is treating the patient for the past 2 years and has already used more than 2 anti-epileptic drugs. This is the broad definition for drug-resistant epilepsy. Like I've said, in the total literature, the chance of a patient being drug-resistant is less than 30%. So why? So for anything, for any disease, you have a natural history. We don't treat common cold. Why? Because if you treat or not treat, the common cold is going to subside in 7 days. That means your intervention is not going to change the natural history of the disease. It's not only neurology, any specialty, you either give a drug or do a surgery, put a knife on the patient. If your intervention is going to change the natural history and the outcome is going to be better than the natural history, then only the intervention is accepted. So what happens? Suppose the scenarios what you are seeing like drug-resistant epilepsy cases. What happens if you leave the patient? Patient continues to have seizures. So what? Patient is not dying. So let us see what happens if you don't treat patient with seizures. You are giving drugs, but patient is not responding and continues to have seizures. You can see in the first line, he continues to have seizures in the first row. Second, as the seizures progress, you try to increase the dose of the medication and you also try to add more and more medication, which may lead to medication toxicity. And the most important is the psychosocial impairment. The student's school performance goes down, there will be family dysfunction, and he may land up in depression, psychiatric impairment, and finally, there is something called as SUDEP, sudden death in epilepsy. So these are all the things, this is a natural history of a drug-resistant epilepsy patient. That means if you don't intervene, the patient is bound to develop all these complications. So what is happening if you do surgery? Suppose the patient is the ideal candidate for surgery. If you do surgery, you can stop all this. You can stop the progression. So your surgery halts the natural history of the drug-resistant epilepsy and can give a better outcome. Are we sure? Are we sure that as epilepsy surgery is better than leaving the patient with 2 or 3 drugs? Yes. So there is this landmark article published in 2001 in the New England Journal of Medicine. See, epilepsy surgery was there in practice since long time, but this is a study which has changed the scenario. This is the randomized study. They have divided the patients, drug-resistant epilepsy patients, into 2 groups. In one group, they offered surgery. In another group, they didn't offer surgery. So this study was headed by Dr. Samuel Weeb. He was there during my tenure in Canada. He was the president for ILA for a long time. So you can see here, patients were free of disabling seizures at the end of 1 year. Those who underwent surgery was 58%, and who didn't undergo surgery was 8%. So you can see there's definitely those patients with temporal lobe epilepsy, drug-resistant temporal lobe epilepsy who underwent surgery. After the pre-surgical evaluation, 58% were doing better compared to the 8% of the non-surgical group. So this study has changed many things. I mean, this study has established epilepsy surgery as a treatment regimen, one of the treatment regimens for patients with drug-resistant epilepsy. So now, this is a randomized study. This is not a simple study. Randomized, blinded, double-blinded study where surgery was offered for 50% of the patients. Surgery was not offered for 50%. And those where surgery was done, they were definitely doing better than those patients who were not treated surgically. So now we know why we should treat a drug-resistant epilepsy and why surgery is a good option for epilepsy, drug-resistant epilepsy. So this is an important slide I want you to go through. So once you diagnose the patient as a drug-resistant epilepsy, you have to evaluate the candidate in terms of candidacy for epilepsy surgery. Not all drug-resistant epilepsy patients can be operated. So how will you know which patient to operate, which patient to not operate? How will you decide? So that is what we call as a pre-surgical evaluation in epilepsy. So what we do is, you see, pre-surgical evaluation is nothing but you should be able to identify the cortical area capable of generating seizures. And if you remove that part, now you see we are cutting a part of the pie here. So if you remove that part of the cortex, then the patient should not have any more seizures. So you should be able to identify that part of the cortex, that cortical zone. So you can see in the figure there, the orange area, EZ, is the epileptogenic zone, the orange colored part. Our surgery aim is to remove the orange colored part, epileptogenic zone. The actual seizure zone is actually called as the ictal onset zone. So you can see the surgical area is bigger than the ictal onset zone. And the yellow colored part is the one which gives you the seizure semiology, like automatisms, limb movements. And the irritated zone is the one which gives you the electrographic evidence. So this is why we do all this, to identify that part of the brain, the section of which will control seizures. So how can you identify? So we now all know that seizure is a electrical activity. So electrical activity you can identify by doing a scalp EEG. So, but a simple scalp EEG is not enough to identify this epileptogenic zone. So what we need is a long-term monitoring of epilepsy, called as a video EEG monitoring. It is the first most crucial step in the pre-surgical evaluation of a drug-resistant epilepsy patient. And the second most important step is the structural MRI. These two are the most crucial steps which will decide the patient candidacy for surgery. So what is this? I think you all must be aware. You do a scalp EEG in your OPDs, but if you do the scalp EEG for days and days together, it becomes long-term. So it is a long-term monitoring for epilepsy. And it is a first and foremost crucial step for patients with drug-resistant epilepsy. So what information you get? So this is the classical appearance what we get. You have a camera, 2 or 3 cameras facing the patient, and the EEG electrodes attached to the patient. Whether he goes to washroom, whether he sleeps on the bed, whether he plays, the electrodes are always attached. And you get a continuous electrical activity. So ideally, you try to capture some 3 to 5 seizures, and average stay in hospital around 3 to 5 days. So what all you can do with this? First and foremost is diagnosis. I think majority of you might have seen patient presenting with tonic activity in your OPDs, but they are not seizures, they are pseudo seizures. So first and foremost is first to diagnose whether the patient is really having a seizure or a pseudo seizure. So diagnosis. Next is the patient is having seizures, classification and characterization. What kind of seizures he is having, whether it is a simple partial, complex partial, generalized seizures, and characterization, like which side of the brain they are coming from, which area of the brain they are coming from. And finally, quantification, like the activity, the seizure activity, the amount of intracranial activity, quantification. So these 3 are the main categories in which the data can be, the data what we get from the video EEG. So this is a classical example what I have shown here. You can see these 3 electrodes here. SP2 and F2 and F8. So they are showing a maximum activity compared to the rest of the electrodes. So this is a classical scenario of a mesial temporal epilepsy onset. In EEGs, you all know like even number is on right side and odd number is on left side. So this is the information what we get from the video EEG. So once you get the information like which part of the brain is responsible for this electrographic activity, then what you do, the next step is take the patient for MRI. So MRI is readily available, like everywhere now we have MRI. And this is what ILA, International League Against Epilepsy, has proposed, a protocol called as the Harness MRI Protocol, which is harmonized neuroimaging for epilepsy structural sequences. So this is a simple thing, like they are given 3 sequences. One is you have to do a T1 weighted imaging. T1 weighted imaging of 1 by 1 by 1 sections, very 1 mm sections, a 3D MRI of T1. And also the same in flare. So you should have 3D T1 weighted images, 1 mm cuts, and 3D flare images, 1 mm cuts, along with sub-millimeter section of T2. So here you can see the cuts usually they go through the hippocampus in a perpendicular fashion. Here you can see this is the coronal section at the level of the head of the hippocampus. Here is the body of the hippocampus, and here this is the tail of the hippocampus. Here in the below images you can clearly see the configuration, the detailed structural anatomy of the hippocampus, right? So this is the harness MRI protocol. So a long-term video EEG and a harness MRI protocol are basic essentials in the evaluation of a drug-resistant epilepsy patient. So what? Now, we did a video easy. We identified seizures to be coming from a particular area. We did an MRI. MRI is showing a lesion, some sort of lesion in a particular area. So both EEG and MRI, they are localizing the seizures to be originating from a particular area in the brain. This is called as concordance. This is a term what we use in epilepsy evaluation. Very important, concordant, discordant. Concordant is all your seizure semiology, the seizures, the type of seizures patient is having, the video EEG, the seizures where they are coming from, and the MRI is showing a structural lesion in the same area. So all the three, they are in concordance. They are all showing you that the seizures are coming from this part of the brain. So what you can do in this patient, you can see in the flow chart, seizure semiology, MRI, video EEG, all three are concordant. You can subject the patient to surgery. Suppose the EEG is showing seizures coming from right side. MRI is showing a lesion on left side. Are they concordant? No. So they are discordant. So that means you cannot do surgery on this patient. Since EEG is lateralizing to one side, MRI is showing lesion on the other side, they are discordant. So if they are discordant or inconclusive, then you need further investigations. So further you have many more modalities of non-invasives like PET scan, SPECT scan, MEG, functional MRI, EEG combined with functional MRI, all these non-invasive workup. I'll just show two non-invasive workups which are practically applicable. So this is SPECT. Suppose MRI and video EEG, they are not concordant, then you subject the patient to SPECT, single photon emission computed tomography. When the patient is having a seizure, you give an injection of a radionuclide dye. So what will happen? The area of the brain which is giving away electrical signals actively will take up more blood flow. So that you can identify on the ictal SPECT. Ictal SPECT is the scan done. Ictal SPECT is the scan done during the seizure activity. And this is the intraictal SPECT. This SPECT is done without, when the patient was not having a seizure. In this scenario, you can see there is a left frontal hypoperfusion in the left frontal lobe, whereas during the seizure, the perfusion has increased. So what you do now, you subtract the intraictal SPECT from the ictal SPECT. You see the change in the rate of blood flow, and you identify the area. So once you subtract the intraictal SPECT from ictal SPECT, you superimpose this image onto MRI. You see the example here. Here the MRI is normal. You can see the MRI is normal. You are not able to identify any structural lesion there. But the SPECT scan is showing a increased blood flow during seizure from the right frontal area, right frontal lateral cortex. And you project this SPECT scan onto MRI. Now you get something called as SysCom. This is SysCom is subtraction of ictal SPECT, which is co-registered to MRI. So this SPECT scan can be projected over the MRI, and then you can see which part of the brain, the structure of the cortex, which is responsible for seizures. This is how SPECT is helpful. But problem with SPECT is you need a radionuclide to be with you all the time. Because when the patient is having seizure, you should give this radionuclide dye, which will be very, very difficult to manage in our scenario. That's why we have the alternative of PET. So PET, what we do, the most common thing what we do is we use 18 FTG, glucose. What happens, PET, patient comes to your OPD, you can simply write, there are many PET centers available in many centers now. You can just send them to a PET scan. So patient, usually they don't have seizures. So what we get is a intraictal PET. So the epileptogenic zone has usually hypometabolism in the ictal area. So you can see a PET scan here where the left frontal pole is showing a hypometabolism. The intraictal PET is showing a hypometabolic focus. So how is this helpful? You see this example here. This guy with epilepsy, drug resistant epilepsy, his seizures are left facial twitchings and along with the left upper limb and lower limb movements. So from this information, we know the seizures are coming from the right side of the brain. So lateralization we got, but we are not sure of the localization. Then we subjected this patient to MRI. And even EEG was showing right lateralization. So seizure semiology and EEG was showing right side onset. MRI, normal. So this is discordant. MRI is not aligning with the seizure semiology or EEG. So inconclusive, we cannot do surgery. Now what we do, you go to next step. You do a PET scan. You see a PET scan of this patient. There is clear-cut hypometabolism on the right side compared to the left side. So it indicates there is a ictal onset from the right temporal. Now you come back. You extrapolate this PET data onto your EEG data on your seizure semiology. If they are concordant, then you can do surgery on this patient. So usually the outcomes are not so great. If MRI is normal, your outcomes will fall below 50%. If your MRI is positive and is correlating with EEG, your outcomes are above 70%. So, coming back to the same slide. So, if MRI and video EEG, they're aligning with each other concordant, you do surgery directly. If they're not conclusive, you do a PET scan or SPECT scan and can do surgery. And even after this, you don't get enough data. Then you subject patient to something called as invasive workup. See, usually you place EEG electrodes on the scalp. The electrical activity is coming from the cortex. So this electrical activity has to cross the dura mater, the bone, and skin. And from there it gets picked up. So to bypass all this, what you can do, you can simply place the contact on the brain itself. So that is these two kinds. So here you can see the dura is open and the EEG electrodes are placed directly on the brain. These are called as the subdural electrodes. You can see the broad area is covered. So if you want a vast area of the brain to be covered, the best technique is to use subdural electrodes. But you don't want broad area. You already have an idea that this part of the brain is responsible. You want a very localized area to be covered. Then you can do what is called as a stereo EEG. Stereo EEG means three-dimensional. So you can just place electrodes, just making through a puncture hole in the skin. You can push the electrode deep into the brain. That is called as a stereo EEG. So I had the chance to work with this system during my training called as ROSA, Robotic Stereotactic Arm. It will not have any frame. It will you just do the planning. It will come and just stay there where the electrode to be placed. You can just make a hole through this and keep the electrodes. And the other side is the frame-based stereotaxy, where you use a big frame fixed to the brain, so fixed to the skull of the patient, and you plan and place the electrodes. So this is the user interface, what you get on ROSA. You can see on the right side, I have named the electrodes and I did the planning. You can see here, on the image here, you can see a lot of contacts. Usually, the depth electrodes will have 10 contacts. You can count the contacts there. This is the MRI done after placement of the electrodes. So this is another MRI showing the electrodes, depth electrodes. You can see the depth electrodes here. There, the depth electrode is on the lateral part of the frontal cortex, going up to the orbital area. So I named it as lateral orbitofrontal, medial orbitofrontal, prefrontal. So these electrodes, they can go to the depths of the brain where subdural electrodes cannot go. So this is the most important slide of my presentation today. So first, you think the patient is not responding to drugs, you label him as drug-resistant epilepsy candidate. So what you do first? You take on all data, you examine his seizures, you collect the history, semiology of seizures, and then you do a video EEG. You could get 3 Tesla, good 3 Tesla MRI. Suppose the MRI and VDs are not sufficient, then you go do a PET, SPECT or functional MRIs. And then what? Suppose the data is aligning, like we have discussed, the data is concordant. Patient accepts the risk for surgery. I mean, we are opening the brain, it's always risky. So patients accept risk for the surgery. Then you go do a surgery. Suppose you see in the middle column, what happens most of the time? Patient's data is not enough to do surgery. If patient's data is not concordant, it is a contraindication. You always should have a hypothesis when you are dealing with epilepsy patients. You are not dealing with a single point. You are dealing with networks. So what you should have is a hypothesis. You should have a hypothesis based on your seizure semiology, EEG. you think suppose the right frontal is the cause for seizure, right? Then your MRI should show something on the right frontal area. Then only you should proceed for surgery. If either of this goes out of the line, then you should not send him for surgery. Outcomes will be poor. So any contraindication? Obviously, medical management or other types of treatment like Dr. Lakshmi Priya discussed earlier. So you should explore other opportunities. And you can see on the right side, the data is discordant. Your investigations are not aligning with each other. Or suppose there is kind of lesion which is exactly on the motor cortex. You cannot resect because the risk is very high. Then either you should go for medical treatment. Sometimes you want more data, then you subject the patient to invasive EEG. And if you think definitive surgery is going to help him, then only you should subject him for surgery, right? So I'm not going into too much details of epilepsy surgery because epilepsy surgery per se is like very vast. And today I'll just limit myself to what kind of surgeries we do for patients with drug-resistant epilepsy. So there are something like resective procedures and functional procedures. In resections, temporal lobe, extratemporal lobe, and sometimes disconnections. Sometimes you disconnect right hemisphere from the left hemisphere, disconnections. And in functional, we have vagal nerve stimulation, deep brain stimulation, RNS, okay? And sometimes you disconnect, you do a corpus callosotomy or subpial transections or hippocampal transections. This is the kind of surgeries what we do. But these surgeries will be done only after all the workup, like what we have discussed in the previous slides. It usually takes around 1 year to come to a conclusion whether you want the patient to subject him to surgery or not. So I'm stressing again, like if you see 100 epilepsy patients, the chance of the patient being a purely drug resistant is less than 10%. And out of this 10%, only 1% will be a good candidate for surgery. So let us get back to our case scenarios. So now we have gone through all this with our improved knowledge. So let us look at the case one. 30 years male, drug-resistant epilepsy. There is a cortical cyst on left side. And the MRI is showing a classical mesial temporal sclerosis on right side. So what you will do now, you look at this seizure semiology. A classical temporal seizures, partial seizures, okay? And video EEG is localizing to right mesial temporal. So your seizure, your video EEG, but MRI you have two findings. But the finding which is correlating with your video EEG finding and the seizure semiology finding is the right mesial temporal sclerosis. And one more important thing, what we do for surgeons, for patients before doing surgeries, we do a neurocognitive testing. See, MRI is showing a mesotemporal sclerosis. Okay, we agreed. Suppose you go inside and remove the hippocampus. What will happen? What are the functions of hippocampus? Memory is the most important thing. We know hippocampus is the cause for seizures. But at the same time, if you remove the hippocampus, patient should not have a bad outcome, right? So what we do is a very important step is the neuropsychological testing before surgery. You look for the functioning of the hippocampus. Usually right side of the right hippocampus is usually concerned with the visual memory. So you give him some visual two tests. There are certain kind of tests. There are a lot of scales, standardized scales to test hippocampal functions. So you can see in this patient we did testing and his memory is less than 5 percentile. That means the hippocampus is dysfunctional. So if you remove the hippocampus, patient will not have any new problem. He will not have any new memory deficit after surgery. So that also you have to keep in mind. Your surgery should not cause, these are all functional surgeries. Functional surgery should not cause any new deficit to the patient. That is the most important point. Whether you operate or not, that is secondary. Your surgery should not cause a new problem to the patient. So all are matching, right? So in this patient, what we did? We did a right anterior temporal lobectomy with resection of the amygdala and hippocampus. So this is the post-op MRI, and this is the intraoperative picture. You can see the head and body of hippocampus. So we have removed the entire amygdala hippocampus along with the anterior temporal lobe. And the patient is seizure-free for the past 5 years and is not on any drugs right now. That is the kind of outcome you get if you identify your surgical candidate according to the literature what we have till now. Now look at have a look at the second case scenario. So look at this patient. He is also having almost the same semiology like the earlier patient. But you see the EEG is a bit generalized. It is mostly lateralized to right side, but not localizing to any particular location like the previous patient. And you see MRI, is MRI helping? MRI is not helping. MRI is normal. So there is no hippocampal sclerosis, there is no cortical dysplasia, there is no cavernoma, nothing on MRI. MRI is totally normal. So what you do? They're discordant. Then you go for the next phase of investigation. So you got a PET scan done. You can see where is the PET, findings of PET. You can see there is a clear-cut hypometabolism on the right side, right insula and peri-insular areas. You can see there is a clear-cut hypometabolism on the right side. So now, I am not very convinced to go ahead and remove the entire right part of the insula, right periopercular, right peri-insular areas. It will become very major surgery. I want more evidence that this part of the brain is the cause for seizures. Then what we did, this surgery was done actually not here during my fellowship, this surgery. So we did this. We kept depth electrodes. We did a stereo EEG, invasive EEG. We kept depth electrodes in the insula. You can see two depth electrodes. One is going into the anterior insula. The other is going into the posterior insula. And these are all the electrical activity, what you are getting. So usually with depth electrodes, what you get in ictal onset is a fast ripple activity. You get very fast waves, fast ripple activity, which is a hallmark for ictal onset. So in this patient, we got that activity from the insular electrodes. We have placed many other electrodes in the perinsular areas, frontal, temporal also, but only these two electrodes gave us the maximum activity. So what we did this. So this is a Sylvian fissure. What you are seeing are the middle cerebral artery vessels. So we did an insular resection. This is a postoperative MRI. You can see we have removed the insula. And patient is not seizure free, but earlier he used to have at least 3 to 4 episodes per week. At the time of my exit, he was having like 3 to 4 episodes per year. So very good outcome. We were able to achieve this outcome because we were able to localize the epileptogenic zone with the help of these depth electrodes. So let us come to the final scenario. Pediatric patient, diffuse onset. He has multiple types of seizures. He has repeated falls, generalized convulsions, jerks, everything. So EEG is not helping. It's diffuse onset generalized epilepsy. So this patient, you cannot subject him to any kind of surgery. So what we can do is a functional procedure like vagal nerve stimulation or corpus callosotomy to avoid falls. So these are the kinds of scenarios. I just broadly have shown you 3 different kinds of scenarios. So for any intervention, we have to look whether the intervention is really useful, whether the side effects are more than the benefits, or benefits are more than side effects. That also should take into consideration. So there is a study published, long-term seizure outcomes following surgery, a meta-analysis. So they found that in temporal epilepsy, 66% of the patients are having Angel class 1 outcome. That means they are doing very good after 5 years. Temporal, and nearly 60% of extratemporal. And you look at the complications there, the major complication rate in epilepsy surgery is 9% and minor is 10%. So overall complication rate in epilepsy surgery is nearly approx 10%. So you should compare those side effects with the benefit of 60%. And you should individualize for each and every patient. So finally, if you look at this, you can look at the names. I am the least important part of the team because the factors which influence the outcome of epilepsy surgery is, first and foremost, like I have said, your EEG should be able to localize the epileptogenic zone. So the neurologist, the epileptologist has a major role here. So to identify the epileptogenic zone from where the seizures are coming from. If you are able to localize, your outcomes are going to be good. If you are not able to localize or pinpoint, your outcomes are going to be bad. The most important, So epileptologist and EEG technician, epilepsy nurses, all form the unit, we call it the LTM unit, is very, very important first step for evaluation. Next comes a neurocognitive status like we have discussed earlier. Because of the long-term epilepsy, suppose the patient has gone into major depression. A patient with a major psychosis or depression, you will not operate, even though there is a lesion on MRI, because the surgery is not going to help him. He is not going to come out of the depression or the psychological issues what he is having preoperatively. So the most important for me is lesion on MRI. See, after coming back to India, I never operated on a patient with normal MRI. A patient with epilepsy with a lesion on MRI is sure to have very good outcomes. More than 70% of them will have a seizure-free periods if there is a lesion on MRI. And finally, you remove the hippocampus and pathologist says hippocampus is normal. Then you are in soup. The outcome is going to be bad. That means patient is going to have seizures back in a couple of years. They'll be happy for 1 or 2 years because you have cut the hippocampus, the networks have changed, you have cut the wires. So the reforming of the networks will take time. So seizures recur after 2 or 3 years if the hippocampus is normal on histopathology. So your pathologist should mention only if it is there, that either there is hippocampus sclerosis or dysplasia. And finally, like we have shown in the first slide, you should be able to resect the entire epileptogenic zone. Sometimes it may not be possible if the epileptogenic zone is involving the eloquent cortex, like motor cortex or speech area. But if you are able to achieve, which will be done by me, then the patient will have very good outcome. Thank you. So I think you must be having a lot of questions. So please feel free to raise your queries. Actually, more common thing what we see is people not responding to drugs, but they're not seizures. So before surgery, I have sent, I think, we have a epileptologist in our city, Dr. Harini. I have sent a lot of patients to her. Usually, I see this very common in pediatric population because most of them refer to me saying it is drug-resistant epilepsy. And I can't spend much time on all those things. So in majority of the cases, we found out them to be pseudo-seizures. They're not seizures. So there is no electrographic activity on the EEG. But the kid will be on 4 or 5 drugs. That we have seen. Coming to surgery, I never took a step to go beyond this line. This is a clear-cut line. I always operate only the video EEG, MRI, and the seizures. They are all in the same line. They're all concordant. Because your outcomes will drastically fall down. But still, even in those patients I have operated, to be frank with you, they, at least some 20-30%, they continue to have seizures. But the seizure burden has gone down drastically. They continue to have seizures because of the reforming of the networks. That we always keep in mind. This failed surgery is a new concept coming up. There are many literature is there where failed temporal lobe resection surgeries, what to do. Now they are terming it as temporal plus syndromes.
Thank you, sir.
Sir, please.
Okay, very good presentation. And most important thing is the epileptologist here. So they should have a good, first of all, patience is there. And application of the knowledge, very, very important here. Which I do come across the people which are very successful in operating, where the institutes are there, where there is a lot of good teamwork. Basically, I came from the Chitra. I went to Chitra Trivandrum. They have the first epileptology surgery, and extensively they made this in the country itself. So they have very good results also. As you said, nearly 70% people have the successful. Nearly 30% they may not do well, even in the institute. But I have spent there for 15 days in epilepsy program also there. So you, as you rightly said, if the selection of the patient is the most important. So there's mostly temporal. There's a temporal epilepsy or temporal focus. They have the more success rather than the non-temporal things, either in the theoretically or in the practice also. So this is a really good option is there if there is a refractory epilepsy. But the most important thing is the epileptologist. And the second is the family support. And I do come across one person recently only, but only anecdotal only say, there is a young fellow. And he was since childhood, since 6 years old, last 20 years he is my patient. And he went to the Google and was influenced by the results from the Google research. And he used to have only 1 or 2 complex partial seizures for 6 months or 1 year. But that fellow was influenced by the Google and he forced his parents to go for a surgery. Just because of the Google only. He became a BTech student and he got an IT person. Unfortunately, because IT, he went to the Google and Google asked him, is it better with the surgery? And he went to a surgery with an epileptologist, and I don't want to name that. And unfortunately, after surgery, he became more epileptic. And he's getting now 2 to 3 attacks per month. And moreover, he's an unmarried man. So that parent came to me and I said, why do you went to the surgery and all? Because he was forced by the Google. So the Google and the social media also are getting influenced with the patient. And this is one negative result because they felt very bad. Now he is an unmarried man and he's getting more seizures and he was put on more now 4 drugs on the patient. Earlier he was only 2 drugs with me and now he's getting worse. He was on the 4 drugs. And then they said, you want to re-operate on him. So this is the thing, Google influence on the medicine also. This is one latest thing which is going on. But you had a very good presentation, and this is a good dictum also. As you said, if they should not have any extra burden after surgery, they should not have any extra deficits. And this is a very good presentation. I will really impressed with this. Thank you.
Thank you, sir.
Thank you, sir, for shedding light on evolving surgical landscape. Now I invite Dr. Keshav Rao, sir, to present a memento to Sridhar Narayana, sir, as a token of our gratitude. From seizures to cognition, we now explore a diagnostically challenging domain, rapidly progressive dementia. I invite Dr. Lakshmi Lavanya ma'am to speak on rapidly progressive dementia, its etiologies, diagnosis and management. Ma'am has done her PG from Siddhartha Medical College and DM from Andhra Medical College. Ma'am has been awarded Dr. K. Venkateshwarlu Gold Medal as a best neurology student from NTR UHS University.
Thank you. Thanks for the introduction.
Good afternoon, one and all. First of all, I would like to thank my friend Krishnaveni and Lakshmi Priya and Kamineni group for this opportunity. Today, my topic of presentation is rapidly progressive dementia, in short, what we call as the RPD. So, usually, whenever we come across the word dementia, usually we thought that it's related to the memory. In poetic way, what we call memory is the thread that stitches together our identity. When that thread begins to fray, the person slowly loses the map of their own life. So coming to the dementia, it's an acquired decline in multiple cognitive domains, not only memory, it's of multiple cognitive domains, which are severe enough to interfere with independence in everyday functioning in a person with preserved consciousness. So coming to the recent nomenclature, the dementia term is changed to the major neurocognitive disorder according to the DSM-5 because to include other domains, that is non-memory related domains for the definition of the neurocognitive disorder. That mild cognitive impairment is changed to the mild neurocognitive disorder. So again, in the etiology, what we have to address is, based on the clinical syndrome and underlying pathology, we have to label the diagnosis. Like predominant with which cognitive domain patient presented, like cognitive impairment syndrome, behavioral syndrome, extrapyramidal syndrome, or extrapyramidal plus syndrome. Based on the etiology like tauopathy, amyloidopathy, Lewy body disorder, or vascular, like that we have to label the patient. So again, in this major cognitive domain, apart from the memory, what are all the other domains are attention, executive function, learning and memory, language, perceptual motor, and the social cognition. And again, in each domain, multiple components are there. So before labeling that particular component is deficit, we need to do set of investigations. So coming to today, our topic of presentation is rapidly progressive dementia. So traditionally, what we call as the rapidly progressive dementia is a condition that progresses from onset of first symptom to the dementia that is declining in any of the cognitive domain to the functional impairment in less than 1 to 2 years, although mostly occur within weeks to months. So according to the traditional definition, there is no clear-cut definition regarding the time frame for the RPD. So among the dementia cases, the percentage of the RPD is around 3 to 4%. But usually in our clinical practice, if we apply all those clinical domain, according to me, that percentage is more than that. So because of the rapidity of the progression, it's considered as the neurological emergency. So according to the new definition, according to 2526 American Academy of Neurology, here included the time frame. So the patient is considered to have RPD if mild dementia, that is clinical dementia rating scale of more than 1 develop within a year of the symptom onset, or moderate to severe dementia, that is clinical dementia rate scale of more than 2 develop within 2 years of the symptom onset. That is 1 in 1 or 2 in 2. Rule is considered as the major neurocognitive disorder of rapidly progressive dementia. So another entity is the ultra-rapid RPD. Here the patient develops dementia of a CDR scale of more than 1 within the 7 days of the symptom onset. So usually in the etiology, these are mostly stroke-related, autoimmune and infectious, or these ultra-rapidly progressive disorders. So this is the scale of clinical dementia rating scale. Here main components are memory, orientation, judgment, problem solving, community affairs, home and hobbies related, and the personal care. And based on this battery of tests and queries, and we conclude a scale. Based on that, 0.5 is the questionable, mild is the 1, moderate 2, and the severe. So according to the RPT, if the patient develop mild of 1 within a 1 year, or moderate to severe 2 to 3 square within the 2, we consider as the RPD. So usually this RPD is an umbrella term. So in this, again, multiple pathological causes are there. And again, in each entity, again, multiple n number of disorders are there. So for this, what we should, in any medical practice, one mnemonic is vitamins. So like this, for the RPDs also, that mnemonic holds good. So V for the vascular. In the vascular, it may be acute onset of stroke involving the thalamus or our memory-related area, or recurrent strokes, sometimes because of dural AV fistulas, amyloid angiopathy, vasculitis. Sometimes subdural hematomas also, chronic subdural hematomas also can presented like the RPD. So in the infections, again, multiple viral, protozoal, n number of infections are there. But what we should definitely address is the most common is the HSV encephalitis. In every case, we should rule out the HIV related. And again, Lyme, Whipples, and neurosyphilis, we have to keep in our mind. And regarding the toxins and metabolic electrolyte disturbances of either hypo or hyper, and again, complications related to that like extrapontine myelinosis and vitamin deficiency like Wernicke's encephalopathy, niacin deficiency. And again, because of systemic causes, uremic encephalopathy, hepatic encephalopathy, all we should keep in mind. And again, porphyrias, hypoglycemia, hypoxic injury, also over a period of time, patient may develop like the RPD type of the presentation. And the recent entity is the autoimmune. It may be of autoimmune etiology or vasculitis or paraneoplastic or that is most common. Another one is the steroid responsive, that is the Hashimoto's encephalopathy. All we should keep in mind while dealing with any RPD patient. And M for the either metastasis or the neoplasm. It may be secondary to systemic disorder or the primary CNS or paraneoplastic related thing. I for the iatrogenic or illicit drug abuse. That illicit drugs like lithium toxicity, methotrexate, some chemotherapy also can be presented like that. And sometimes neurodegenerative disorders itself can be presented like the RPD presentation. The most common entity prototype for the RPD is the prion disease. Sometimes even Alzheimer's FTD can be presented. Even in the recent literature, according to neurodegenerative disorders, still the most common percentage for the RPD type of the presentation. So last one is the either systemic or structural lesions like sarcoidosis, sometimes chronic epilepsy, silent epilepsies, non-convulsive can be presented as the RPD. So while dealing with the RPD, what we should keep or what principle we should follow is always prioritize reversible causes before labeling the degeneration, and we should emphasize placed on the neurological examination, and we should use that neurological examination for our reasoning for the investigations and for the final conclusion. So in the RPD, the neurological examination may vary person to person, examiner to examiner because of rapidity of development of the clinical signs. So we have to keep every time that type of presentation, and we have to apply the investigations accordingly. So this is the study recently published in the 2024 meta-analysis. In this, still the most common cause for the RPD according to percentage wise is a neurodegenerative disorder, followed by the neuroimmune, that is autoinfectious, followed by the CNS infections, prion disease, vascular dementias, metabolic, toxins, intracranial, and the NPH hereditary. NPH is also we should be considered. Yesterday itself we have admitted a case presented like one year history of PSP type of presentation, clinically clear-cut presentation of PSP, but my surprise on the imaging, it's the NPH type of the presentation. So based on the timing frame, usually like ultra rapid type of phase, usually we have to rule out vascular, infectious, at the same time autoimmune. Sometimes prion disease also can be present, like recently 3 months back we have seen a case presented with the acute onset of Broca's FSA type of presentation presented within the 48 hours of the presentation. So we have to keep our mind very broadly while dealing with the RPD type of the presentation. Over a period of months, it can be vascular, infectious, or inflammatory autoimmune. Over a years, most commonly neurodegenerative and neurovascular, we have to consider throughout the phase of the course. So this is the graph showing based on the rate of progression. At the same time, if you intervene in the early phase, the potential reversibility is very high in the autoimmune, toxins, metabolic and drug abuse or infections or systemic causes. So in the middle phase of the neoplastic and the vascular, in the slow phase of the neurodegenerative, and the prion disease comes into the middle phase but without any reversibility chances. So this is the graph showing, the study showing three groups comparison. In the group 1, they have compared the cases of RPD before 2012, and the group 2, 2012 to 2017, and group 3 is after 2018. In group 1, the most common cause for the RPD is neurodegenerative disorder, followed by the autoimmune. In the group 2, it's a neuroinfectious autoimmune. In the group 3, again neuroinfectious autoimmune, because widespread of knowledge and investigations, so that cases are recently evolving into the treatable reversible causes. This is a very interesting study. Here cases are referred to a prion center, Jacob-Creutzfeldt disease referral center, where initially labeled as the neurodegenerative prion disease, but after that referral to those centers, they work up again, its breakdown as the non-Jacob-Fold rapidly progressive dementia. So before labeling any neurodegenerative disorders, we should consider and thoroughly work up other treatable causes. It's a very important. Otherwise, over a period of time, irreversible damage may occur and patient will land up into the irreversible stage. So while dealing with the RPD cases, so initially on clinical ground, we have to label, and possible etiological thing will guide a clue to how to follow and how to approach. And again, we have to keep that mnemonic vitamins during the history-wise and also during the workup-wise. So if you can find out based on the set of the investigation, metabolic screening in every patient we have to rule out, and imaging based on that we can have a clue. Based on that, CSF or other modality of the investigations we can choose. And again, CSF, if based on that infectious or inflammatory, we have to rule out. Again, if all the investigations are negative, so we have to consider for the giving of the high-dose methylprednisolone. And if the patient is not improving, we have to consider for the brain biopsy. Sometimes patient may need repeating set of the investigations over a period of time to come to the conclusion. So this is the thing published in the Continuum. Because of the rapidity of the nature, widespread of the investigations, every time we may need battery of the investigation, but always clinical examination and the history will guide us which type of the investigation we have to choose. So we have to rule out metabolic and the infectious causes, imaging, and again CSF. In that CSF, infectious, autoimmune, paraneoplastic. So if we are dealing with any neurodegenerative, or if we are going to label as a neurodegenerative, we must rule out autoimmune, paraneoplastic, other possible infectious before labeling as a neurodegenerative disorder in case of the RPD cases. So according to this study, according to the author, if the patient is financially affordable and available test, doing of these biomarkers 1433, total tau and a neurospecific anomalous, even though those are usually we think that this 1433 is for the prion disease, but it only indicates the rapidity of the neuronal loss, so that it will guide us how much fast we have to rule out and we have to start the treatment, it guides us. So while choosing the investigation MRI-wise also, we have to go according to the first modality of the investigation, contrast. After that PET, we have to consider during the follow-up course. So coming to the CJD, once it is considered as the prototype of the RPD, so main thing is the rapidly progressive dementia. Along with that, myoclonus, visual and cerebellar signs, pyramidal, extrapyramidal signs, akinetic mutism. And based on the variant type of the CJD, we come across the other things. So in the EEG, usually what we see is the periodic shortwave discharges. Positive 1433 CSF is some sensitivity is there, but recently RTQK has the 100% specificity and sensitivity of the 96%. So, but before labeling as a prion disease, we have to rule out other treatable causes. So, in the MRI, usually what the findings we have seen in CJD is either symmetric or asymmetric, diffuse or focal, cortical ribboning type of the pattern. In the cortical ribboning pattern, sparing of this Rolandic area will give the clue. Usually in CJD, this perirolandic area is spared. If it is involved, again we have to consider for other possible etiology is there or not. And again, involvement of the striatum and the basal ganglion, especially in the variant CJD, pulvinar and the double hockey stick sign. But these can be possible in other etiologies also we need to consider. So the most common findings in the CJD is cortical ribboning sign and sparing of the perirolandic area and the cerebellar atrophy. And unusually we can see is the involvement of the pulvinar and the double hockey stick and the cerebellar involvement also. So this is the case patient presented with 58-year-old lady with a rapidly progressive dementia, insomnia, myoclonus and cerebellar ataxia of the 3 months duration. MRI brain imaging suggestive of cortical ribboning pattern and EEG also suggestive of periodic shortwave discharges. But on routine workup, patient is having the autoimmune etiology of GABA-P antibodies. But after methylprednisolone, IVIG, still patient progressed and succumbed in predominantly progressed over a period of time with akinetic mutism and the myoclonus. So for this, the positivity of the GABA-B receptors might be because of the secondary phenomena occur because of the damaging of neuron because of the prion proteins leading to the release of neuronal antigens and the false positivity result. So presence of the autoantibodies may be misleading, but we have to consider our clinical clues for final labeling of the disease. So I'm not going to in detail about the definition of the autoimmune encephalitis. Usually patient presented with various type of dementia, cognitive, psychiatry, movement disorders, and we have to find out coming to various types of the autoimmune encephalitis, which clinical finding will guide us to choose which type of the antibodies. So usually NMDA type of receptors are present in young patient presented with the psychiatry type and movement disorder type of the symptoms and also the dysautonomic features. So we have to rule out other possible malignancy or paraneoplastic type of things in these type of patients. In LG1 type of patient, usually elderly presented with seizures, in the 2 seizures of the faciobrachial dystonia type of the seizures we will see, and plus or minus hyponatremia we can see. In GABA-B usually presented with seizures, and Casper usually patient presented with along with RPD, patient may presented with neuropathic and myarrhythmia type of presentation and ataxia. GABA-A usually presented with irreversible drug-resistant status epilepsy type of the presentation. MOGAD usually presented like ADM type of presentation. GAD is like a patient presented with like a stiff person type of syndrome type of presentation. AMPA patient presented with encephalitic type of presentation. DPPX usually presented predominantly gastrointestinal like persistent diarrhea, weight loss type of presentation. And the recent entity is the IGL4 diagnosed recently 2014 from onwards. Here patient predominantly presented with NREM REM type of behavior along with the stridor type of the presentation because involvement of the thalamus and hypothalamus predominantly. These are the MRI imaging clues for the autoimmune encephalitis. Usually limbic type of pattern is seen with the anti-LGI1 pattern, but again we have to keep in our mind that HSV encephalitis steroid responsive type of and also the granulomatosis while dealing with these type of the imaging features. Striatal pattern usually seen with the anti-CV2 and CRMP5 type of pattern. Again we have to keep in our mind that prion diseases. Perivascular enhancement type of pattern we see with the GFAP type of pathology, but we have to keep in our mind again neurosarcoidosis and lymphomatoid granulomatosis. Predominant diencephalon and brainstem pattern usually seen with the anti-MAR2 type of presentation, but we have to rule out the neuroinfectious type of pathology, especially melioidosis, Behçet's and the listeria. So cortical type of pattern usually seen with the GABA A receptor. Again, when we have to rule out infections and the stroke. MRI negative pattern also can be seen in the autoimmune encephalitis, especially NMDA type of presentation. So this is one thing which can give the clue that autoimmune encephalitis versus HSV encephalitis. Usually HSV encephalitis very rapidly progressive with the seizures, psychosis with clinically. Pneumonic is the virus, and it shows the intensive cortical swelling and hyperintensity on the flare, which shows the rapid evolving of the findings on repeated MRI scans, and it may be unilateral or bilateral predominant temporal involvement, whereas autoimmune encephalitis is medial temporal involvement and sometimes basal ganglion, but HSV usually spares the basal ganglion. So while dealing with the autoimmune encephalitis, based on the etiology and based on the investigation, so we have to start the treatment as early as possible to protect the neurons. IV methylprednisolone followed by plus or minus IVIG and plasma exchange. Usually combination of the therapy is very important, and simultaneously we have to work for the other etiological causes, and we have to address for the all seizures or other supportive care we have to give. If the patient is not improving, immediately we have to escalate the treatment to protect the neurons. Second line tire is the either rituximab or cyclophosphamide. If not improving, the third, we have to go for the third tier of the treatment. With the recently one for the MOGAD is the tocilizumab is approved. And again, other thing as the anakinra, bortezomib, we have to consider. So while dealing with the autoimmune encephalitis, our goal is we have to identify early, treat early, and we have to escalate the treatment is also early to protect the neurons and to see the potential reversibility. Another recent entity, IgNO5 disease. Recently what we consider it as the crossroads for the autoimmune encephalitis and the neurodegenerative disorder, because along with the autoimmunity there is tauopathy in these pathologies, so that we can see the predominant cerebellar atrophy. Usually the patient presented with the NREM and REM sleep type of pattern and stridor and predominant brainstem symptoms because of hypothalamus and the brainstem involvement. Here HLA type of pattern association is also seen. This is the case. 70-year-old woman presented with amnesia, gait disturbances, aphasia over 2 weeks, followed by the development of the progressive reflex myoclonus, followed by the tetraparesis with brisk reflexless and pronounced extrapyramidal symptoms, and over a time of progress to the akinetic mutism. This is the scan of the patient. Any guess? Okay. Here we can see predominant bilateral hyperintensities. Clinically, here looking like the prion disease. On imaging, predominant hyperintensities in the white matter. This is the clue for this patient. There is prominent vascular markings. So for this patient, on DSA, finally find out as the dural AV fistula presented as the rapidly progressive dementia.
I think ఇది
ముందే వచ్చేస్తుంది. స్లైడ్ షోలో లేదా? ఓకే. So this is a patient of 50-year-old man, alcoholic, hypertensive and hepatitis, presented with nausea, vomiting and diarrhea of 3 days duration, and he stopped his alcohol consumption with excessive free water consumption, and 1 week later find out as the hyponatremia and treated for this. And after that, patient developed hallucinations, rapidly progressive dementia type of the pattern, and gait disturbances and also myoclonus. On imaging, the patient is having hyperintensities in the bilateral basal ganglion. and on workup and ruling out other possible etiologies labeled as the extrapontine myelinosis. This is the another patient, young patient, presented psychiatry patient, extreme religious, doing over fasting. Over a period of time, patient presented with rapidly progressive dementia type and neuropathy, nystagmus and gait disturbances. On imaging, patient is having pulvinar type of pattern, usually we see in the variant CJD type. And on routine workup, because of his clinical nature, on thiamine infusion, thiamine treatment, over a period of time, complete disappearance of this pulvinar sign was seen. This is the case of reversible pulvinar sign in the Wernicke's encephalopathy. So here again a case of Wernicke's encephalopathy. The patient presented with typical cortical ribboning type of pattern and also presence of periaqueductal and the pulvinar side type of pattern. This patient is also showing low B1 levels, and after thiamine deficiency treatment, there is improvement in the symptoms. Again here the misleading is patient is also having the periodic sharp wave discharge type of pattern. So even the brain scans support a rare diagnosis, imaging should always be interpreted with the clinical background. So this is again another patient, 55-year-old female, presented with complaints of change in behavior, excessive fear, forgetfulness, irritability, crying spells, and the aggressive behavior and hallucinations, presented over a period of 5 to 6 months. On workup, CSF VDRL is positive. Here the patient is having little bit hyperintensity in the brainstem, finally diagnosed as the neurosyphilis, presented as the RPD. This is a case of 30-year-old female presented with dressing apraxia and left side confusion, dyscalculia over 3 months of period. On imaging, patient is having disproportionate cerebral atrophy according to her age and predominant white matter changes in bilateral, frontal, temporal, and also in the external capsule. So on workup, on genetic pattern, finally find out as the acute onset leukodystrophy due to this variant type of presentation, but clinically as the RPD with Parkinson's type of presentation. So this is the another patient of 58-9-year female presented with confusion, myoclonus, and progressive dementia type of the pattern, and even on imaging, patient is having predominantly of the cortical gray matter hyperintensity like cortical ribboning type of presentation. On the CSF is also patient is having 14-3-3 positive and predominant tauopathy, but on spectroscopy, patient is having high lactate peak and CSF lactate is also very high, and over a period of time patient developed new lesions. So based on this, patient is, even though presented like prion type of presentation, clinically also 14-3-3 CSF analysis is positive, but over a period of time the pattern of imaging and rapidity of the progression labeled as the MELAS as the RPD type of the presentation. So final conclusion is we should always prioritize reversible causes before labeling any neurodegeneration. We should much focus or emphasis on the neurological examination and reading our own imaging for good reasoning and for good suggestion of the investigations. Do not forget the basics that common things are common, and we should verify time course. Often symptoms begin earlier than the records what we state according to in the documentation. Be thorough by using the mnemonic vitamins while dealing with the RPD. CJD is the great mimicker. It can look like anything, vice versa. Do not rely on 14-3-3 for the CJD diagnosis. It represents CSF biomarker for the rapidity of the neuronal decline, not for the prion diagnosis. And diagnose infections, inflammatory, other treatable conditions, and we should keep in mind while dealing with the RPD. MRI with other appropriate sequences we have to keep in mind, and we have to choose other modality of the infection, and finally brain biopsy if all the investigations are negative. Thank you.
Now the session is open for questions. Thank you, ma'am, for that structured approach to a complex clinical scenario, ma'am. Now I invite Dr. Krishnaveni, madam, to present memento to Dr. Lakshmi Lavanya, madam. Thank you. Thank you. We break now for lunch. Kindly be back by 2 p.m. to continue the academic sessions.
ఒక్క నిమిషం ఫోటో అది కాదు నాది ఇక్కడ టాపిక్ ఎక్కడుంది అమ్మా బాబు ఓకే ఇది డిలీట్ చేసాను డిలీట్ ఎలా చేస్తాను కదా ఓకే
వచ్చింది సార్
ఇది ఒకటి నాది ఒకటి ఇది జల్లి ఉంటుందా
హ్యాంగ్ అయ్యింది సార్ పీపీటీయా సార్ హ్యాంగ్ అయిపోయింది ఒకసారి
నిశ్చల్.
రాలేదన్నా కాదు మేము ఇది మార్చాలి మేము అక్కడి నుంచి వాళ్ళు
ఓకే ఒకసారి జస్ట్ రాస్తాను.
So coming to the definitions and epidemiology, so these are the evolution of definitions over the years, but the European Headache Federation have classified these entities into two variants, that is the resistant migraine and the refractory migraine. So both entities are different and they have labeled the criteria for that. So for resistant migraine, patient has to satisfy the criteria for migraine according to ICHT-3. And the patients need to have debilitating headaches that are lasting for greater than 8 days a month for at least 3 months. And there should be failure of 3 preventive classes of medications, and medication overuse entity might also be coexistent with the resistant migraine. Whereas coming to refractory migraines, again patient should satisfy the criteria of migraine according to ICHT-3. But the difference between the resistant and refractory is patient should be having debilitating headache lasting greater than 8 days per month, lasting for at least 6 months, and there is failure of all the preventive classes of medicines, and medication overuse is usually coexistent. So before we label the headache as refractory, so we need to address the medication overuse and treat accordingly. So coming to the resistant migraine, as we already discussed, it needs failure of 3 preventive classes of medication, but the only hope we have in resistant migraine is it is still treatable. Whereas in refractory migraine, it requires failure of all the preventive classes of medications, including the advanced therapies like the CGRPs and even the Botox injections fail to respond in the refractory migraine. So treatment becomes quite challenging in refractory migraine for a neurologist, but always remember the entity of medication overuse, because in the recent times, like we have addressed a case of resistant migraine. So where the patient was been put on 3 preventive classes of medications and 2 classes of acute medications, but still the patient was resistant to treatment. So on probing her, she gave us a history that she has been on a daily dose of Ultracet, and since the pain is not subsiding, she has already taken the bupropion patches, almost 5 patches she has taken in the last 1 month, and she presented to us with a refractory headache. She presented to us with a medication overuse headache, but not taking proper history. We have treated her like a resistant migraine, but we went into the history deeper. Patient is having a medication overuse, and when we addressed that issue, patient responded slightly better. So while treating refractory and resistant headaches, we need to focus beyond the percentages. We need to focus on the burden of the residual days. That is, for example, if a patient has 15 migraine days in a month and we have started them on preventive class and the patient responded almost 50%, so there'll be roughly around 8 headache days a month, but still 8 headache days are still debilitating for a patient to lead a normal life. So in treating resistant and refractory cases, we need to focus beyond percentages. We need to focus on the burden of the residual days. So what is the reason? What are the pathophysiological aspects and the factors contributing for resistance? So these are the factors that are contributing for the resistance. So usually these resistant migraines, they have medical comorbidities like fibromyalgias, irritable bowel syndromes, which are highly associated with the central sensitization, which lead to treatment resistance. And these patients might also have psychiatric comorbidities like depression, so which leads into a chronic migraine. And these patients are resistant to treatment because all the depressive patients and the resistant cases will have a hyperactivity of the limbic system, making them resistant to treatment. In addition to that, high continuous stress levels leads to treatment failures, and the patients will be involved in medication overuse. So coming to the basis for the resistance, we all know that central sensitization is the key aspect in any state of persistent pain. So what is central sensitization? Central sensitization is nothing but the lower threshold for pain. So why is it occurring? So in migraine specifically, central sensitization, there is a lower threshold for the trigeminal system, so which is the key pathophysiological system involved in migraine. So because of this repeated nociceptive input, the neurons in the CNS, they become hyperexcitable. So why do they become hyperexcitable? It is because of the neuroplasticity changes that happen in the brain. So what are the neuroplastic changes in states of chronic pain? So usually there are structural and functional remodeling of the synaptic contacts of the dorsal horns. There is reorganization of the cortical sensory maps, and there is increased activation of the limbic system noted in these cases of persistent pain. So all these together, the patient pain system becomes oversensitive and patients go into a state of resistant or refractoriness. So the second most important system is the trigeminal vascular system. So activation of the trigeminal vascular system from its innervation of the intracranial vasculature to the meninges is the chief one which is active in chronic migraineurs that possibly leads to the neurogenic inflammation and pain. In resistant cases, this system is constantly on. That is, the neuropeptides or the neurotransmitters released from this system are chiefly the CGRP, which we'll be discussing in the later slides, and the other neuropeptides like the pituitary adenylate cyclase activating peptide and the substance P. In addition to these, a hyperactive hypothalamic and limbic dysfunction has also been noted in resistant and the refractory cases. Coming to the neurotransmitters and biomarkers, so a lot of debate is going around the CGRP. So CGRP levels have been increasingly found in chronic migraine patients, so it can be subserved as a biomarker in resistant and refractory cases as well. So in these resistant and refractory cases, there are increased levels of CGRP. In addition to CGRP, studies have also found that there is dopaminergic dysfunction and hypersensitivity of the D2 and D3 receptors in these resistant and refractory cases. So, and it is also suggested by the fact that olanzapine, which is an atypical antipsychotic or a dopamine antagonist, has been found to be efficacious and working in a few patients of resistant and refractory headaches. Apart from that, the other role of the other neurotransmitter is the glutamate. So the glutamatergic transmission, the glutamate levels are significantly increased and its transmission is also increased, leading to central sensitization and treatment resistance. So apart from these pathophysiologies, what else could have contributed to these resistant and refractory headaches? So the patient might experience the reduced placebo effect, they might experience the increased nocebo effect, and because of the medical and psychiatric comorbids that are not addressed properly, patient might progress into a state of refractoriness, and the poor diet and sleep habits, low socioeconomic level where it keeps for the patient to continue the preventive class of medications for so long, low socio-economic level is definitely a hindering factor, and delayed or access of medical care, and when there is a misdiagnosis of migraine, and lack of effectiveness of the preventive treatments, and some patients might experience adverse effects of the preventive treatments and discontinue their usage. So these are the other factors responsible for the migraine refractoriness. So what are the management and treatment strategies available for this resistant and refractory headaches? So coming to the management strategies, so we need to focus on communication, we need to focus on preventive and acute treatments. So for resistant migraine, we need to reassure the patient that it can still be treated, but whereas refractory migraine, it's a challenging job for a neurologist to actually settle down the refractory migraine. So coming to optimizing the acute treatment, we need to either switch over to another acute treatment, or we used to use combination therapies. Coming to preventive treatments, we need to use either combinations, like drugs having different mechanisms of actions, and we need to give an adequate trial and adequate dose of preventive treatments before we label them they are ineffective. So coming to the treatment of resistant migraine, the key features you need to keep in your mind is partial response is still present, and this entity is still treatable. So treatment options are still existent, they're not exhausted, but it might improve with the proper dose optimization or combination therapies, and if we address the comorbidities and lifestyle modifications, might help in treating resistant migraine. But we need to focus on resistant migraine because continuous failures of treatments of resistant migraine might progressively worsen the patient, and he might go into a state of refractory state where the treatment is almost challenging. So this is a stepwise protocol for treatment of a resistant migraine. So you need to confirm the diagnosis first. So confirm the diagnosis of migraine with or without aura. Please exclude medication overuse before you treat this, and rule out the secondary causes like the CSVT, the IIH, and the intracranial space occupying lesions. Step 2 is identify the factors that are contributing to the resistance. Is it poor compliance? Is it like inadequate dose or duration? Is it medication overuse? Or is it the coexisting psychiatric comorbidities and poor lifestyle disorders? And other hormonal triggers need to be addressed. So next, step 3 is optimize the acute treatment. So the routine NSAIDs used for the acute treatment, we all know we either use paracetamol or naproxen or diclofenac. And coming to triptan, sumatriptan is widely used. So if they are ineffective, try to combine them. So combine an NSAID with the triptan, and if possible, add an antiemetic like the metoclopramide. But remember, I see many of the patients coming to me, they only use acute therapies, but they fail to use the preventive therapies, where an entity called as the medication overuse is present if we overuse the NSAIDs for more than 10 to 15 times a month. So that is quite challenging to treat a medication overuse headache. So step 4, optimize the preventive therapy. So before you label any treatment ineffective, try it in adequate doses and try it for adequate duration. So for migraine, it is almost like 8 to 12 weeks of trial should be given. So please don't change the preventive medication before this duration. And these are the first-line preventives we commonly use for the treatment of a migraine headache. If still resistant, then please try in combinations with different mechanism of actions. For example, you can combine an anti-epileptic drug with a beta blocker, or you can combine a tricyclic antidepressant with a beta blocker. So if all the above therapies fail, consider advanced therapies, that is the CGRP therapies. We all know the monoclonal, this is the recent advance in migraine. So the monoclonal antibodies for preventive therapy are the anti-CGRP monoclonal antibodies, that is the erenumab, the fremanezumab, and the galcanezumab. And the GPANs, where the GPANs are the treatment for acute therapy of migraine, but the recent studies say they can be used for acute as well as preventive therapy. But for preventive therapy, it is an alternate day regimen, not a daily regimen like the other classes of preventive therapies. So all these CGRP therapies, they block the CGRP ligand, which is the chief neurotransmitter involved in the pathophysiology of migraine. For chronic migraine cases, we have another option apart from the CGRP therapies, that is the Botox. So the Botox should be given at least for the Botox should be given at least for every 12 weeks for the treatment response. And the dose and duration, I'll be specifying it in the next slides. And if all the above therapies fail, we are left with neuromodulatory options, both non-invasive and invasive. And then the next step, after addressing all the comorbidities, if all the above steps fail, then we are not dealing with resistant migraine anymore. We are dealing with the refractory migraine, which requires a multidisciplinary approach and an inpatient detox. So these are the advances in acute migraine therapies. So these are the Japans we are talking about. So the FDA has approved ubrogepant and rimegepant for acute therapy for migraine. So the dosages are, for ubrogepant it is 50 or 100 mg, and for rimegepant it is 75 mg. The contraindications are they should not be given along with the CYP3A4 inhibitors. The most common side effects witnessed are the hypersensitivity reactions and the GI side effects. And the other drug is ditans, that is, these are the 5-HT1F receptor agonists. So in contrast to triptans, which are the 5-HT1B and 1D agonists, so these have lesser vasoconstrictive effects when compared to triptans. So these can be used in patients like cardiovascular, hypertensive patients, and other vascular risk factors patients. So these ditans can be used. The only limiting factor is excessive sedation. So what is the AHS consensus statement regarding the use of this anti-CGRP therapies? Can we straight away start on any patient? No. Only when there is failure of 2 to 3 classes, preventive classes of medication, we can consider using these anti-CGRP medications if the patient is having a severe documented disability, and in cases of chronic migraine, if the Botox also fails, we can consider starting this anti-CGRP therapies. So these are the respective anti-CGRP therapies. The following are the drugs: eptinezumab, the erinumab, the fremanezumab, and the galcanezumab. So usually these are monthly once administrations because they have a half-life of 27 to 30 days. They can be administered in the subcutaneous form. They are like infusion injections. So the half-life being 27 to 30 days. The most common side effect we see are the infusion reactions and constipation. But the only important limiting factor is they are highly costly. So each injection would cost around 50 to 80,000, but they're still not yet available in India, but they're available abroad. And coming to the Botox, so these are the sites where we infuse Botox for chronic migraine cases. So we use a total dose of 155 units, and these are the sites where we infuse, like for corrugator, we infuse 5 units, and for procerus, we infuse 5 units, and frontalis, we infuse 5 units on each side, and for temporalis, we infuse 20 units on each side, and occipitalis, we infuse 15 units on each side, and cervical paraspinals and trapezius, we infuse 10 and 15 units respectively. So till now we have dealt with resistant migraine. So how do we approach for a refractory migraine, where there is failure of all the preventive classes, failure of all the advanced therapies, including the CGRPs and the Botox? So it requires a multidisciplinary approach. It requires a neurologist, a psychiatrist, and a pain specialist. And it requires like a psychologist for a behavioral therapy, the cognitive behavioral therapy, and for giving biofeedback. And we need to address on the lifestyle factors as well, like sleep optimization. And step 2, we are still left with the neuromodulatory options, be it invasive or non-invasive, And step 3, we need to focus on experimental or the emerging therapies, like try a different class of a Japan, try a different ditan, or try the drugs that are coming up in clinical trials. So coming to neuromodulation, so these are the non-invasive and the invasive neuromodulatory techniques: the vagal nerve stimulators, the supraorbital nerve stimulators, and the transcranial magnetic stimulators. Coming to the invasive neurostimulatory techniques, we stimulate the occipital nerve, the spinopalatine ganglion, and the deep brain stimulation of the ventral tegmental area. So these are the non-invasive neuromodulatory technique. The first image is the vagal nerve stimulator. The second image is the supraorbital nerve, that is a branch of trigeminal nerve stimulating the supraorbital nerve. The third image is the transcranial magnetic stimulator. And the fourth image is a TENS. It is called as nervi vivo. So it is a handheld device that can be used in migraine. So these are all the non-invasive neuromodulatory options that can be tried in refractory cases. So the main pathophysiology or the mechanism how these neuromodulatory techniques like reduce migraine is that by the stimulation, they inhibit the pain pathways in the trigeminal cervical system, and they alter the corticothalamic circuits, and that is the way they modulate pain and they reduce the pain. So to summarize, so resistant and refractory migraine, resistant is still treatable, refractory is almost untreatable. So it is like failure of 2 to 3 classes of drugs, and it is failure of all the preventive classes. So advanced therapy also fail, Botox also fail in refractory migraine, and often reversibility, resistant is still reversible, but refractory is rarely reversible. So medication overuse may be coexistent. So please consider that entity before you treat resistant and refractory migraine. Resistant still carries a better prognosis, and refractory carries a worse prognosis. So what are the future directions? So what's happening beyond CGRP? So there are other drugs that are been in trials, so specifically targeting the pituitary adrenalate cyclase activating peptides, and the drugs targeting the glutamate, the drugs targeting the dopaminergic and the endocannabinoid systems. So these are the future therapies of migraine. So migraine care has been shifting from a trial and error treatment to a targeted mechanism-based treatment. So to conclude, so treating migraine early will prevent migraine from going into a chronic state, from a chronic state to a resistant and refractory state. So we need to treat it at the earliest. Thank you.
Now the session is open for Q&A. Raina sir to kindly present a memento to Kamineni ma'am as a token of gratitude.
Sir, I'll come down. Sir, I'll come down.
No problem.
Advances in neuroimaging are transforming neurological diagnosis. I invite Dr. Sushan Kumar sir to speak on role of arterial spin labeling in neuroimaging beyond stroke. Sir has done MD radiology, fellowship in interventional neurology. Sir is pioneer in his field, now working as assistant professor in NRI Medical College, associate professor in NRI Medical College, senior consultant in Swanner Scans.
ఇదే యూస్ చేస్తాం. So after that energetic lecture from Krishnaveni ma'am, so I will try to maintain at least 50% of her energy. Otherwise, don't blame me. You just blame the good lunch over there. I still remember the days where I used to work as an intern under madam. I used to always escape from the duties, and she used to always catch me. Some things don't change, and I still have to be careful. So can I get, reduce these lights? So my images are more colorful and all. So you can off these lights. You can switch off these lights as well. So being radiological images and all these will project well with low light. Only these. I don't want those audience to be dull. Yeah, perfect. Got it. So as we think of ASL, so how many of you people have ever seen ASL images? Please raise your hands. So arterial spleen labeling, have you ever seen these colored images when you see the films? How many of you are neurology residents or who are practicing neurologists? Okay. So as we think of ASL, most of us basically think of stroke. So as a perfusion maps or to detect the penumbra zones. But ASL actually can see far beyond the ischemia, and it tells how the brain functions. So today we'll explore how simple a perfusion technique has evolved to detect the functional changes in the brain. So before I go into the lecture, I would like to acknowledge the organizing team of this academic CME program for giving me this opportunity and giving me help to exchange the knowledge. So I basically divided the talks into two halves. One, we'll understand the technique of ASL, then we'll look into how it translates into the clinical practice. So basically ASL is nothing but a sequence like T1 or T2, but we should have a specialized software for it. It is a gadolinium free MR perfusion technique, so you don't need to give any gadolinium. It basically uses the magnetically labeled arterial blood water protons as an endogenous tracer. That means it uses the protons in our body itself to produce the perfusion images. How we will come to know, and it can actually detect the quantifiable CBF in classical units, which is the ml per 100 grams per tissue per minute. So it is just a 5 to 10 minute sequence, that's it. So how does it works actually? So if this is the brain and this is the vasculature, how it looks. So we will take a image first. This is called as a image 1, and then we will label with an RF pulse where you tend to listen sounds from the MR, tuck, 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 tuck. So this is one of the RF pulse. So you label it, and the labeled blood flows through the brain, and it labels the entire brain vasculature. Then you take another image, then you get a second image. So if you look at the first image, it is without labeling and is called as a reference image. Then the second image is with labeling, we call it as a labeled image. But you don't see any difference. So the difference is as low as less than 2%. So you don't see it with the human eyes. So what we do, we actually subtract these images and we'll add some math using the software. Luckily, we don't need to do anything, and we'll get the final ASL images like this. We can also get, I will skip this. So this is a 5 to 10 minute sequence. We'll do the same thing multiple times to get some difference which is visible with the human eyes. So we will take almost 20 to 200 times the same thing, then you will tend to see some difference between the cortex and difference between the white matter, then difference between any other abnormal areas. So then the same can be reconstructed into the colored maps. So these are the final ASL image where we tend to look at. So once we get this image, we can actually put an ROA, region of interest, and we will get the absolute CBF value. So where this is the CBF value, where how much ml of blood is flowing through 100 grams of tissue per minute. This is the value which we can measure actually. So if we are exploring the clinical spectrum, the most commonly used since past more than a decade, they are using in a stroke, and from the past 5 to 6 years there are many researches coming in multiple various pathologies. So in stroke, basically there are classical patterns to detect penumbra. So I will explain the classical patterns by showing two examples. So this is the first example where this is an MR angio image where there is left M1 occlusion. You don't see any signal in left M1. Then obviously due to this occlusion there is a large infarct in left MCA territory. So the area of diffusion is generally called as a core. Then if you look at an ASL image like this, so there is it is completely blue in color, where this blue in color indicates this low perfusion. So the area is hypoperfused. So the area of diffusion and the area of hypoperfusion are equal. So it indicates that there is diffusion and perfusion match, and also tells that there is no penumbra. So there is no penumbra in it. Whereas coming to the second case, this is an MR angio where you can see complete occlusion of right MCA here, and if you look at the diffusion areas, they are very small areas of infarctions are seen. But if you look at ASL, see this larger area of perfusion defect is seen here. So the hypoperfused area in this is not equal to that of diffusion restriction. That means there is diffusion and perfusion mismatch, which indicates that there is a large penumbra. So if you treat this patient in whatever way you do, if the patient is in window, you can do a thrombolysis. Even if it's out of window, you can try a mechanical thrombectomy and all, and you can save this the area which is impending to get a stroke. So these two examples are what is happening during the ischemia or when the patient presented with infarct. So what ASL can do when the infarct already happened or out of window. So it can actually detect the arterial thrombus, it can localize the thrombus, it can detect the post-therapeutic changes once you treat the stroke patient, then it can also detect multiple stroke mimics. For example, how it detects the arterial thrombus. For example, there is this sign called as a bright vessel sign. So I will tell you how it works. So it corresponds to accumulation of labeled arterial blood protons. This is more of a physics. So that means if the blood is flowing like this, and if there is an obstruction here, so the blood on the proximal portion gets pooled there. So that you can see how, I will tell you, if this is a thrombus here, and there will be pooling of blood just proximal to it like this. So this indicates a slow or stagnant flow. So I will show you this with this example. This is a case. Obviously there is an infarct on diffusion restriction, infarct on diffusion. Then on SWA there is this small focus of blooming, which we call it as a susceptibility vessel sign, indicating a presence of thrombus. And on ASL, if you see, there is a small area which is red in color. This indicates that there is a thrombus here, and just proximal to it there is pooling of blood. So the blood is getting accumulated there. So indicating this is the cause of stroke for this patient. This is called as a bright vessel sign. And in the distal sections, so you can see a hypoperfused area which is not equal to that of the area of stroke. So again, it also says that there is a diffusion perfusion mismatch, and this thrombus needs to be taken out. This also works in posterior fossa. So this is a case where there is a large brainstem and bilateral cerebellar infarctions, very bad. And this is a SWA image where there is a susceptibility vessel sign in the basilar artery. So you can see the same in the ASL where there is a small red signal in the just proximal to the basilar and also in the right vertebral artery. So there is thrombus here and there is pooling of blood and entire basilar also in the right vertebral. So how can we detect the post therapeutic changes? How ASL will help in a patient after treatment? So it can detect the areas of luxury perfusion which are areas of hyperperfusion. So the term luxury perfusion is actually a misnomer. It is not something luxury what we feel happy. For example, this is a case which I showed you. This is M1 occlusion, large infarction and large perfusion defect. So surgeon wanted to or the interventional radiologist tried to take out the thrombus, and good that the thrombus has come out, and in angio the vessel became normal post treatment. But what's happening on ASL? If you see on ASL, there is large red areas there. So this is called as a luxury perfusion, and you should not be happy when you see this. So why? So for example, this is normal. These are the oxygen in the brain parenchyma. So when there is an infarct, so there will be no oxygenated cells which is going to that area, and you see a hypoperfused defect. And once you treat that case, once you remove the thrombus, there will be more and more of blood going into that area, and the oxygenated cells gets pooled in that area. So why? There are multiple reasons. One is the oxygen demand in that neurons may be low because some cells have already died. Then there is insufficient usage of oxygen from the RBC because due to the infarction some cells are already stopped or about to die. So then they might not entirely utilize the oxygen. Then there is a loss of auto-regulation. Due to all these factors, these oxygenated blood gets pooled in that infarcted zone. So what is the end result when you see this? End result is it will bleed there. So there will be a hemorrhagic transformation. So whenever you see luxury perfusion, you can tell the patient that you are going to have a bad prognosis rather than just being happy. This is how it going to help. So we'll discuss how ASL helps in diagnosis of stroke mimics by looking at these 4 examples. First case, always clinical history is very important. A 36-year-old female presented with sudden onset left-sided weakness and confusion. So if you look at the diffusion and flare images, there is no abnormality. It's absolutely normal. We can't stop there. There is weakness. So we tried ASL. So ASL, there is diffuse hypoperfusion in the entire right cerebral cortex, which is not limited to a vascular territory. It is not in MCA territory. It is not in ACA or PCA territory. It is entire cerebral cortex. So this is a classical case of migraine in aura phase where ASL revealed a diffuse hypoperfusion. So we did a 24-hour follow-up for this case. So again, there is no abnormality in diffusion, but ASL again recovered with hyperperfusion. So because there is the auto-regulation and all, these cells will try to take more and more oxygen because of previously hypooxygenated state. So this is a classical case. ASL sometimes can pick the stroke mimic. This is also another case where there is a 54-year-old female presented with severe right-sided headache and left-sided weakness. On diffusion, there is no infarction. On flare, also there is no abnormality, but there is some chronic hemorrhage in the left lentiform nucleus. And if you look at the ASL, there is hyperperfusion in this right cerebral hemisphere, which is indicated with red arrows. So this is a classical case of migraine in headache phase. So we did a follow-up after 3 days after treatment, then it recovered back to normal. Next is an interesting case, recently diagnosed. This is a 65-year-old presented with mild right-sided weakness and blurring of vision. So if you look at the diffusion, there is an area of diffusion restriction. There is a low ADC value in that areas. But on T2 and flare, there is no hyperintensities, which you look for whether it is in the window or it is out of window to call it to do the thrombolysis or not. Here there is no hyperintensities. In fact, there are slight hypointense areas in this. So 100% it will be thought as infarction in a window period, and you will proceed for thrombolysis. But no. So ASL diagnoses this mimic, and if you look at ASL, there is hypoperfusion in that location, and it is not an infarction, and it is a classical case of hyperglycemic encephalopathy. If you do an RBS for this patient, it will be on a higher side, around 300, 400, and that is the cause of weakness for this patient. Last mimic, which is a seizure with sudden onset left-sided weakness. This is an area of diffusion restriction here, which is not again limited to a single territory, and there is hyperperfusion in the involved regions, which is a classical case of partial epilepsy, and it is not a stroke, which is most commonest stroke mimic, and you can see hyperperfusion in the involved location. So I am going to discuss this in the next section. So till now we have discussed how it helps in the infarction, how it's helping beyond infarction. But there is one more fascinating scenario where ASL can help before the patient got infarction. How it helps? So it detects early hypoperfusion, it detects early vascular steal, and it can also detect pre-symptomatic flow asymmetry. I will show with one example due to interest of time. So this is a patient who presented with transient ischemic attack, presented with again left-sided weakness. So there is no infarction in diffusion, but on angio you don't see any signal in the right ICA, MCA or in the right sided territory, but there is no infarction. So we try to do an ASL. So in ASL you see this is a red color which is there. So this is the bright vessel sign in the petrous segment of ICA, in the cavernous segment, and also up to the M1 origin. So there must be some obstruction distal to it, and there is a stagnation of the blood proximal to it. So to understand, to better explain you, for example, what must be happening here. So this is the vasculature, and there must be a thrombus here, and there is pooling of blood just proximal to it like this. That's why there is no signal on MR angio, and this is an acute thrombus, patient presented with weakness, and this is an area of penumbra, and patient did not present stroke. So this penumbra also got detected on ASL where there is a large hypoperfused defect. So my intervention radiologist took out this thrombus, and luckily patient didn't get any infarction and got treated with the thrombus. So before infarction. So how ASL helps in case of infection. So I will show 5 examples for you just to explain. So this is a 44-year-old patient arrived at emergency department who was unconscious and with high-grade fevers. So this is a flare image where there is abnormal hyperintense signal in the left hippocampus, mesial temporal lobe and all. And if you do an ASL, there are areas of hyperperfusion. Once with this kind of history, unconscious and all, and with this imaging, you will directly diagnose this as viral encephalitis. So this is most commonest is the herpes encephalitis. So this differentiates from a low-grade glioma as well. So we will see this example how ASL can precede the MR findings, which is not detected on conventional MR, but ASL changes have come. So this is a case where this is the flare, there is no obvious abnormality, and there is no infarction, but the patient is having, he must be presented with unconscious and fever spikes, seizures. So here this is the ASL image where there is significant hyperperfusion in the left hippocampus and amygdala. So this was was given as an autoimmune or viral encephalitis, and it turned out to be autoimmune encephalitis. So next example is how ASL helps in differentiating the mimics of infection versus tumors. So perfusion tells a story. So usually infections are low perfusion and in tumors are hyperperfusion due to the vascularity and all. For example, this is a case where there is a large lesion with extensive edema and all, hypointense lesion. So on post contrast there is significant peripheral enhancement, thick rim of enhancement. Some must be confused whether it is a tumor or whether it is infection and all. You do an ASL, you will get the answer straight away. It is not a tumor, it is not a lymphoma, not a glioma, because it is hypoperfused on ASL, and you can give it the straightforward diagnosis of a tuberculoma. The next scenario, this is a T2 image which we got. The patient presented with emergency in unconscious state. So attendees has given history of fever 4 days back. So once you see this type of images, bithalamic lesions, bithalamic abnormal areas, you will have a long list of differentials like this, ranging from viral encephalitis to metabolic or toxic encephalopathy. But with only one sequence, without looking at other sequences, you can shortlist the differentials from a long list to a shorter list, which is the bithalamic glioma or lymphoma, because there are areas of hyperperfusion here. Once there is hyperperfusion, it is not an infarction, not a venous area, which is not a toxic encephalopathy, and it should be a tumors with hypervascularity. Next case in infections, which is ASL, in how it helps in immunocompromised patients. So this is a 67-year-old uncontrolled diabetes presented with seizures. This is a T2 image. There are nodular areas of altered intensities, and on post contrast there is like patchy nodular enhancement in the high frontal lobe. Looking at this and in the clinical scenario, it looks like an infection, but we'll see the ASL. So ASL hyperperfused. Okay, you must be thinking, always you told that infections are hypoperfused, but why it's coming hyperperfused? Yeah, this is a case of angioinvasive aspergillosis, where there is so much of vascularity and inflammation happening there, so you can get hyperperfusion in these cases, which is angioinvasive type. How it helps in epilepsy. So this is where, so after stroke, ASL actually evolved into helping patients in epilepsy, then comes infection. So now I will tell you how it helps in epilepsy. So it can be performed before, during, or immediately after the ictal event without any contrast. So it provides superior temporal resolution compared to the SPECT as well. So this is a case of status epilepticus, where there is diffusion restriction in the right occipital lobe, and there are low ADC values, a larger area compared to that of diffusion. You must be thinking that this can be an infarction, but if you look at the ASL, there is significant hyperperfusion. So it is not an infarction when there is hyperperfusion. So this is a case of status epilepticus. Next case, a patient presented with multiple episodes of seizure. So what you can see on FLAIR is there are some abnormal areas here, there is some abnormal area in the parietal lobe as well. So patient presented with multiple episodes of seizure. You don't know which area is responsible for the patient's epilepsy. If you look at the ASL, so the only area which is responsible for epilepsy is hyperperfused, and rest of the areas show no significant change. So this is how it helps in locating the epileptogenic zone, and also helps to differentiate between the chronic gliotic changes. So what happens in the area responsible for the seizure? So what happens is there will be a prolonged or extraordinary activation of the neurons. There is increased glucose and oxygen requirement in that area. The end result is the compensatory regional hyperperfusion. So we are going to detect this hyperperfused area and tell the clinician that this is the area which is causing the seizure. And next case, this is a case of post-ictal phase patient We did an MRI where there is a high diffusion restriction and low ADC value. So this indicates a cytotoxic edema. And on ASL there is hypoperfusion, and this is a classical postictal edema. So where there is complete neuronal exhaustion in that region and there is hypometabolism. So ASL bridges the gap between the metabolic transition from the cortical overdrive to the recovery. So you can see the hyperperfusion during the seizure. Also you can see the exhaustion of the neurons after the seizure by ASL. So last but not the least, how it's going to help in the tumors. So you can predict the tumor grade. You can track the tumor progression. You can actually look at the, you can actually help the clinician in preoperative planning and biopsy targeting, and it can distinguish areas of tumor recurrence from areas of radiation necrosis. So this is a case. So this is diffusion, you don't see any abnormality. On FLAIR, there is some abnormal signal in the left hippocampus, and on ASL, you can see that there is an area of hypoperfusion here, and on spectroscopy there is significant choline peak, reduced NA. So this is a classical case of low-grade glioma, and it is not a herpes encephalitis. Next case, yeah, this is a obvious looking tumor. So how it's going to help you? So you can see on ASL, that means without contrast, you can actually predict the vascularity, how much vascular it is, and you can be prepared when you are going for the surgery. So this is a hypervascular tumor, high-grade glioma and all. So this is how it's going to help. So it actually correlates with the tumor vascularity and the grade. And this is a very nice, interesting case, a 2-year-old baby presented with vertigo and vomitings. So this 2-year-old baby, remember, so this is a T2 image where there is a large lesion in the posterior fossa, and on post contrast there is intense near homogeneous enhancement here. So obviously, what will be your first diagnosis? Someone? Correct. So first diagnosis will be medulloblastoma. You will be prepared, you will explain the families and all, but you look at the ASL here. So it is not hyperperfused. Medulloblastoma is a high-grade tumor, never hypoperfused. So after looking at the ASL, my diagnosis was a solid type of pilocytic astrocytoma, which is a low-grade tumor, good prognosis and all. So, and this is what it turned out to be in the HPE. So this is a solid type of pilocytic astrocytoma. Next, we can track tumor progression with ASL. How? So this is a case in April. I don't know, it's not projecting well, definitely. So this is a ASL image. So where there is hyperperfusion here. So looking at this area, there is a small dot of enhancement. It can be neglected, but this area of ASL cannot be neglected because there is increased angiogenic activity, and in the immediate next 4 months, you can see this increase of this dot nodular enhancement there, and that persistent angiogenic activity in the same area, and again 6 months later. So this almost reached the size of the primary tumor here. So now the clinician was like, okay, yeah, now this is time to remove it. So this nodule can be removed at the first phase only if you have confidence on ASL like this. So this actually detects the escalation before the visible morphological change in the brain parenchyma. So next case is a ASL, how it helps in the post-operative planning. This is a infiltrating tumor. Almost entire brain is infiltrated with ill-defined areas, extensive involvement, but you don't know where to biopsy it or something. So you can pick up the sites like this, where there are areas of hyperperfusion here, and if you get a biopsy from these sites, yeah, you will get a better yield and immediate cure after the biopsy. So, but unfortunately, this patient didn't turn up, and after 1 month he presented in an unconscious state. So this is how it's completely infiltrating the corpus callosum, the ventricular margin and all, expired after in the next 2 months. So you can also detect the tumor recurrence versus radiation necrosis or pseudoprogression. So this is the initial post-op scan. There is no mass, no enhancement. This is just a granulation tissue over there. So after temozolomide and RT, there is a nodular enhancement which you can see, and you must be so sad thinking that there is a recurrence at the resection margin and all. But using ASL, there is no areas of hyperperfusion. Yes, good. At least there is no tumor, and this is just a case of pseudo progression, and there is no tumor. So when an enhancement lies, ASL comes to rescue. So ASL, which began as a stroke sequence, today it has the language of the brain physiology, and it quantifies the physiology when the structure appears normal. Then it is a gadolinium free. You don't need to give any contrast. Patient friendly, easily repeatable, and now the future of the functional MRI. So ASL doesn't just judges an image, it understands the brain physiology. Thank you.
Now the session is open for questions.
Sushan, for the last case we discussed
I'm
about
scared.
the right...
What are you going to ask?
No, nothing. The right thalamic abscess, like which we discussed
Correct.
previously. We did an ASL for that, for her.
There's no ASL in Kamineni.
There is no ASL in Kamineni. Okay, thank you. So because we were confused in that case scenario, we had a right thalamic abscess. Recently we dealt with a 70-year-old female who presented to us with headache. So there was a big abscess in the right thalamus, but we were confused among the DDs of a bacterial abscess versus a tumor. So since did ASL help in that patient? That is what I'm asking. But we didn't do an ASL sequence in her. And finally it turned out to be a bacterial abscess because we did a stereotactic biopsy and she turned out to have like a positive streptococci in that sample.
Thank you.
Thank you, sir, for expanding our perspective on advanced neuroimaging. Now I welcome Dr. Vinati Madam to present memento to Dr. Sushan Kumar, sir, as a token of our gratitude. Thank you, sir. With an aging population, neurosurgery is adapting to new challenges. Now I invite Dr. Sridhar Narayana, sir, to enlighten us on geriatric neurosurgery.
Okay, all right, so I am back again after lunch. Our tummies are full, AC is good, time to sleep. So I'm here to wake you up all. So I have changed my topic in this last 1 hour. So initially I thought of discussing something with the geriatric neurosurgery. So you might be wondering, you might have attended a lot of conferences where you discuss about pediatric neurology, pediatric neurosurgery, and a lot of pediatric things. But lately I have noticed like India will face the burden of geriatric issues as time progresses. Can you switch off this slide, please? So, today I want to introduce something called as frailty, the concept of frailty to all of you. I think there must be a lot of other department people here, general medicine, critical care, pulmonology, neurology, right? So this thing is applicable for each and every one of you, because this is the standard of care what is already being implemented in Western countries, and we are not yet implementing in our country. At least the places where I am working, or I have gone to many places in India, even the major corporates and major institutes, we are still not using this frailty indices. So what is this? Just like, suppose just you got a call from the ER, you are a critical care specialist, or you are like orthopedician, or some other specialist. For example, I have taken an example of neurology here. So you got a call saying a old lady, 80-year-old lady presenting with CVA. She has no comorbidities, but age is 80 years. You get another call, a 65-year guy came presented with stroke, but he is diabetic, hypertensive, a chronic alcoholic, and smoker. So you compare these two, just keep in mind, like we are seeing two different scenarios. A 80-year female with no comorbidities, a 65-year male with multiple comorbidities. So what influences the outcome in those two scenarios? I mean, we already know if patient has comorbidities, the outcome will not be so good as in those patients who are not having any comorbidities. But how to quantify? Let's go into this. Let's go deeper into this topic. So why this topic matters? So just like 2 hours back when I was talking to you about the epilepsy surgery, I got a call from my friend in Australia that his father is not responding. They live in Vijayawada, he lives in Australia. Out of 30 classmates, I mean, in my 10th standard, 29 members are in US now. I am the only guy staying in India because I am the only guy who took BPC and did BBS. So most of their parents are being taken care by me now. So I get a lot of calls. So all of them are almost 50, 60 plus now. So I get repeated calls like falls at home or having some kind of heart issues. Most commonly we are seeing MIs these days. But lately I have seen in literature that I am not the only guy facing this. Entire world is having this issue. That's the global population is aging. So last week, if you have seen, like our government has proposed a financial incentive if you can have a third child. So you can, so you can see how grave the situation is, that you want more younger people, not older people. But for the next coming 20-25 years, you are going to face the issue with geriatric population, and majority of the inpatients in your hospital will be geriatric patients, not middle-aged or pediatrics. So there is global population aging along with the increasing number of elderly patients across all specialties. Previously, only cardiology and neurology used to see this population group, but I think now majority of the departments are having geriatric patients in their categories. And the one more change what I have noticed is people, like last week I operated a GBM, a high-grade glioma. He came with the right hemiparesis. So I operated. Luckily, a tumor was far from the motor cortex. So his hemiparesis is improved. But his power was grade 2, which has improved grade 4. Now he comes to me and keeps asking me, I'm not able to walk. So I want to be fully fit. He wants to come to the state where he was before diagnosis. So there are the expectations in elderly. If you compare maybe 10-15 years, the expectations were not so high in the elderly population. They used to just stay at home and face whatever consequences they are having from their ill health. But nowadays, because of the increased access to the literature or what you say, comforts of life, the elderly people, they're having a higher expectations. So they will keep you under a lot of stress that they want their functional status back. So till now, we used to see the main parameters, what we used to assess is age. As age, for example, 70 years, 80 years, irrespective of the diagnosis, irrespective of the representation, we used to say they usually have a bad prognosis, like older the age, the graver the prognosis. And clinical status and radiology. Just now we had a mind-bending presentation from Dr. Sushen, how radiology is, the new trends in radiology are improving the outcomes. So we are all familiar with the age, clinical status. For example, in neurology, you see the Glasgow Coma Scale, GCS. It has been there since ages, but still it is very good. So we know there's age, clinical status, and radiological things. They are the traditional predictors. How do you predict the outcomes? But with the advancing things, now we are getting the modern predictors. What are they? Instead of age, we are using now frailty. So frailty, what is the functional reserve the patient has and the physiological resilience. So we should be able to quantify these things so that we can plan the management according to these parameters. So what is frailty? So I kept on saying frailty, frailty. So what is frailty? So frailty is basically a biological syndrome which is characterized by a decreased physiological reserve, which we expect as age progresses, along with impaired stress response and a higher risk of adverse outcomes. You have a high risk of adverse outcome not because of your age, it is because of your frailty. So just if you want as symptoms of frailty, you can say patients, they often feel very fatigued, exhausted, losing weight, or repeated falls, social isolation, psychosocial issues, okay, moving slowly, needing help for daily activities, urinary or bowel incontinence. So there are all the few common symptoms we talk in terms of frailty. So frailty is not just physical. If you can see here, it is made of 4 domains. One of it is physical. So either problems with locomotion, slow gait, weakness, or exhaustion, physical. Other domain is cognitive. Like we had discussed about dementia's previous lecture. So dementia's, cognitive decline, Alzheimer's, memory loss, delirium. So they all form a cognitive domain. Another one is a functional domain. The falls risk. See, falls is a very, very important topic in elderly. If you look, whenever you've been to US or any other West country, you can always see signboards about falls. They are very, very cautious about falls in elderly and reduced mobility. And finally, nutritional domain, weight loss, malnutrition, low energy. So these are the 4 components. So frailty is a multi-dimensional syndrome. Okay, so now we are just talking in general terms like frailty should be evaluated in each and every patient. How to quantify it? How do you say this patient has certain score? So for this, there are multiple scales given. If you can go through the web, there will be lot of scales or indices given to quantify a frail score. I have just given 3 most important indices which I think are very, very applicable to you. So one is a frail scale, other one is a F55 frail score, another one is a risk analysis index. If you can have this chart downloaded from web and paste in your OPDs or the casualties or wherever possible. So this is the simplest form of quantification you can do for a patient. You can just look at the image, you look at the patient and see where the patient fits in this 1 to 9 and you just give him the scale. So this is called a clinical frailty scale. So just for example, you look at 1, patient can run, he's so fit. You look at 5, he needs a stick or other walker as support to walk. You look at 8, he's on bed. You look at 7, he's wheelchair bound. So basing this simple clinical picture, you look at the patient and you can give him a score on this clinical frailty scale, that is CFS. At this point, I think I can show you a simple website where you can actually log in. I think even the systems are feeling drowsy now. 3 o'clock post lunch. Why is this not projecting there? Sorry for the brief hiccup here. So I want you to take a notice of this website, e-frailty. So whenever in your clinic you want anything about frailty, this is the best website where you can find all the tools, where you can just go to this website and see all the kinds of tools that are available here. So you can, if you want, I can show a simple thing here. Like you see this frail scale. So there are a lot of indices. So in this, you can just select, like you can see how much of the time during the past 4 weeks did you feel tired. Suppose the patient says, most of the time. And by yourself and not using aids, do you have any difficulty walking up 10 steps? He says, no difficulty. And do yourself, without using aids, can you walk several hundred yards? He says no. So any of these chronic health conditions he has, suppose he has diabetes, I think majority of our patients have diabetes. Suppose he has CKD, he is hypertensive, and that should be done. And loss of weight, have you recent loss of weight more than 5%? No. And view result. And see the result. So he's pre-fail. That means he's fit enough. So you can see here, 1 to 2 is pre-fail, 0 is non-frail, and 3 to 5 is frail. So what is the significance? So this is a simple scale you can use just for within 1 minute you can quantify the frailty of a patient using this index. Whereas for surgeons, there is something more complicated like a risk analysis index, which has got nearly some 30 points. I'll just show you here, risk analysis index. So it takes into consideration a lot more things. You can see it takes into age, gender, so is he under any assistance, any renal issues, congestive heart failure, how is his walking, gait, loss of weight, so taking all these things. So there are multiple tools like this which can quantify the frailty index of a patient. Yeah. So I think this is also very simple one. You can see this slide is also showing the application part of the frailty index. You see this is called as a minimal frailty index M5 score. There are 5 things here: diabetes, hypertension, congestive heart failure, COPD, and non-independent functional status. And you can see non-independent functional status was the most predictive index variable. A higher frailty, that is more than 2 value, was associated with more discharges to destinations, but not home. Destination can be a graveyard or a old age home, so but not home. So if MFI score is more than 2, the chance of him being discharged in a good healthy state is very, very less. So you can see in geriatric, like this study was done in general surgery patients, inguinal hernia patients, and you can see pneumonia, discharge, not to home, length of stay, mortality. All these 4 complications were very high if the frailty index is more than 2. So can we modify it? We all know we cannot modify age. Age is irreversible. So frailty can be modified. I think few things like, for example, weakness, a loss of muscle power, you can modify with physiotherapy. Anemia or any nutritional deficiency, you can modify with nutritional replenishments. And prior prompt cognitive assessment and cessation of smoking and alcohol, like lifestyle changes, they may bring a mild improvement in your frailty score. So what impact does it have in your day-to-day practice? For example, if you look at the surgical parts like general surgery, orthopedics, neurosurgery, if you think the patient is fit level, then you can proceed with a standard surgery. Suppose the patient is mild to moderately frail, mildly frail, then you can optimize the comorbidities. Suppose he has uncontrolled diabetes, uncontrolled hypertension, you can manage it, bring it under control, and then do the regular routine surgery. But suppose the patient is moderately frail, so literature clearly says you should not do a routine surgery, a standard resection procedure on these patients. The patients with moderate frailty should undergo either minimally invasive approach or a limited surgery, like a biopsy kind of picture, but never a full-fledged long surgeries. And patient with severe frailty, you should neither operate nor treat him intensively. So these are the guidelines what we got from the frailty-based surgical decision model. So finally, if you see, frailty predicts outcomes better than age and allows personalized surgical decision making, and it should become a standard preoperative assessment. So my take-home message is you can start applying this frailty concept in our clinics or hospitals and standardize the patients not just by age, by frailty score. You can take any of the scale. I have shown you multiple scales here. You can select any of the scale and use it, quantify the frailty level of the patients, and you can prognosticate them better. So age is no longer the main predictor of the outcome. So move from age-based exclusion to frailty-based stratification. So finally, concluding in the first slide, we have seen a 80-year female and a 60 years male. So a fit 80 is better than frail 65. Suppose if you are not aware of the frailty concept, you think since person is 80 years, his outcome may be poor. But with this frailty index, application of this frailty scores, now you can confidently say, this 80 years guy is going to perform better than the 65-year guy with comorbidities. Thank you.
Now the session is open for Q&A.
Yeah, you can suggest anything because this concept is new for me. Actually, I have seen a lot of old age homes in US and Canada where they gather all the old people at one home and take care of them. I think a lot of old age homes are coming in Vijayawada too. So,
నా ప్రాక్టీస్లో 70 years దాటినా నేను చూడని చెప్తా. నేను చూడను కూడా. ఎందుకు నాకు 70 ఏళ్ళు బతికాం కదా ఇంకెందుకు ఎందుకంటే అని చెప్తాను. ఇప్పుడు విన్నాక నాకు కూడా ఎన్లైట్మెంట్ వచ్చింది. యాక్చువల్గా ట్రూత్ ఏంటంటే 100% 100 people పుడితే ఓన్లీ 8 people ఓన్లీ క్రాస్ 65, 4 people ఓన్లీ క్రాస్ 70, ఓన్లీ 2 people విల్ క్రాస్ 75. అవుట్ ఆఫ్ 5,000 people ఓన్లీ 1 reaches 80. 10,000 peopleలో ఓన్లీ 1 reaches 85. సో నేను కూడా ఇలాగే రాంగ్ కాన్సెప్ట్ మోస్ట్లీ ఇప్పుడు రాంగ్ కాన్సెప్ట్ అనిపిస్తుంది నాకు కూడా. నేను బియాండ్ మా ఓపీలో కూడా బియాండ్ 70, 75 నేను యాక్సెప్ట్ చేయను. వాళ్ళు చెబుతాను వెళ్ళిపోయి జనరల్ ఫిజిషియన్స్తో ఉండిపో, నీకు ఎంతకంటే తిరగబాక. నేను కూడా 70 తర్వాత 70 చేరితే నేను ఏ ట్రీట్మెంట్ చేయించుకోనే చెబుతుంటా. కానీ ఇప్పుడు చేస్తే మోస్ట్ ఫిట్, నాకు ఐఎమ్ వెరీ మోస్ట్ ఫిట్. ఐ డోంట్ హ్యావ్ ఎనీ సింగిల్ డిసీజ్ అండ్ ఐ కెన్ స్విమ్ ఎవ్రీ డే, ఐ కెన్ డూ ఎక్సర్సైజ్, సైక్లింగ్ ఎవ్రీ డే. సో ఇప్పుడు నేను కూడా కాన్సెప్ట్ చేంజ్ చేసుకోవాలా. నేను పాప చాలామంది 80 వాళ్ళకే తెలుసు బియాండ్ ఓల్డ్ పీపుల్ వస్తే నేను ఓపీ యాక్సెప్ట్ చేయను. నేను వెళ్ళి గో టు యువర్ ఫ్యామిలీ డాక్టర్ అని చెబుతుంటా. కాబట్టి డాక్టర్ శ్రీధర్ చెప్పిన కాన్సెప్ట్ నాకు కూడా ఎన్లైట్మెంట్ వచ్చింది. ఎందుకంటే నిజం వీ హ్యావ్ టు చేంజ్ అకార్డింగ్ ద టైమ్. సో మనం ఓల్డ్ పర్సన్ అయినా కూడా హెల్తీగా ఉన్నప్పుడు సర్టన్లీ యూ హ్యావ్ టు థింక్ అబౌట్ ఇట్. నౌ ఐ హ్యావ్ టు చేంజ్ మై ప్రాక్టీస్ ఆల్సో. Very good presentation, really good, and made it as something scales and I like that.
Thank
very
you,
good, very
Thank
good.
You. Thank you.
Thank you, sir, for highlighting the importance of frailty assessment. Next, neuromuscular disorders are entering a new era of classification. To discuss nodopathies and paranodopathies, I invite Dr. Krishnavini ma'am.
Capture. Yeah. Good afternoon once again. I'm back with a new topic, the concept of nodopathies and paranodopathies. The term might be new, but we have been dealing with these nodopathies and paranodopathies since a long time, but we don't know the pathophysiology and the concept behind this. So we know, we traditionally categorize the peripheral neuropathies either as demyelinating or axonal. But these days, newer antibodies targeting the proteins at the nodal and the paranodal regions have been increasingly recognized, and these are termed as our nodopathies and paranodopathies. So how are they different from the routine peripheral neuropathies we see in our daily clinical settings? So these nodopathies or paranodopathies, they have a clinical phenotype which is similar to GBS or CIDP, but they differ from GBS and CIDP in the treatment aspects, in the aggressive nature of the disease, and the electrophysiological findings. So this is the structure of a neuron we are all familiar with. So this is the structure of a myelinated neuron. So we can see the axon hillock, the myelin sheath, the Schwann cells secreting the myelin sheath, and the nodes of Ranvier and the axon terminals. Today, we'll be focusing mainly on the nodes of Ranvier. So this is the structure of a myelinated neuron. So the myelinated neuron is categorized into 4 domains. So that is the nodes of the Ranvier, the paranode, the juxtaparanode, and the internode. So what is the importance of nodes of Ranvier? We all know that it lacks myelin. Here, the axolemma is chiefly in contact with the extracellular fluid. And we all know it is rich in voltage-gated sodium channels, which are responsible for generation of the action potential and are responsible for saltatory conduction. Coming to the paranode, here, if you see the myelin loops, maybe the pointer is, okay, the pointer is not working. Here, the myelin loops are compacted loosely. Here, the myelin loops are compacted loosely. And coming to the juxtaparanode, in the juxtaparanode, we have the voltage-gated potassium channels, which are responsible for the hyperpolarization of the membrane. So this is coming to the anatomy and the molecular organization of the node. So coming to the node, so here are the important cytoskeletal elements, the cell adhesion molecules, and the extracellular proteins responsible to maintain the structural integrity of the node, paranode, and the juxtaparanode. So what are the important proteins that are responsible to maintain the structural integrity of the node? So if we see here, the axonal membrane near the node contains the voltage-gated sodium channels, and the most important proteins at the nodal region are the neurofilament 186 and the gliomedin, and the ankyrin and spectrin, which are responsible for the structural integrity. If we come to the paranodal region, you can see here the myelin loops are loosely compacted, and the most important protein complex here is the contactin Casper complex, and which binds to the neurofilament 155 on the myelin sheath. Coming to the juxtaparanode, the most important channels here are the voltage-gated potassium channels, and the most important protein complex is the Casper2 and the TAG1, which is responsible for the functional and structural integrity of the juxtaparanode. So, and along with this anatomical and molecular organization, there are also gangliocytes that are located on the axonal membrane as well as the myelin sheath. So these gangliocytes are nothing but the glycolipids, so that are present on the nodal as well as the paranodal axolemma. They can be present on the Schwann cell membrane as well. And these gangliocytes, they interact with the nodal proteins, and they offer stability to the axon-glial interface, specifically at the node and the paranodal junctions. So we are all aware of this action potential and its phases and the respective ion influxes and effluxes for the generation of action potential. So I'll be dealing it with in the next later slides. So if we see, the upper one is a normal axon. So where there is accumulation of the positive ions that trigger the opening of the voltage-gated sodium channels to open up at the threshold. So leading to propagation of the action potential to the next adjacent node. So the upper one is a normal myelinated neuron where there is normal myelin. So because of the sodium channel influx, the action potential propagates to the next adjacent nodes. Whereas the figure B, there is segmental demyelination, so which leads to the current leakage. So there is failure in the propagation of action potential to the adjacent node. Figure C is the axonal degeneration, where there is the axon is non-functional and it leads to conduction failure. Whereas the nodopathies and the paranodopathies, what we are discussing right now, here antigen targets, the antigens on the axolemma and the myelin sheath are targeted by the antibodies, and they actually stimulate the inflammatory cascade via two mechanisms. It might be complement dependent, it might be complement independent. So this inflammatory cascade leads to the paranodal myelin detachment, the nodal lengthening, the disruption of the voltage gated and the voltage gated sodium and potassium channels, and leakage of current, which leads to conduction failure secondary to nodo and paranodopathies. So how is the electrophysiology different from a routine demyelinating and an axonal neuropathy in these nodo and paranodopathies? So normally, we label a neuropathy as demyelinating if we see a conduction block, if we see temporal dispersion, and if we see reduced conduction velocities in the electrophysiology. Whereas we label the neuropathies as axonal if we see reduced compound muscle action potentials. When reduced muscle action potentials, we label the neuropathy as an axonal neuropathy. So, but what happens in these nodo and paranodopathies? What are the chief electrophysiological findings in contrast with the routine demyelinating and the axonal neuropathies? So first one is the normal electrophysiological finding, where you can see the distal and the proximal CMAPs. Coming to the demyelinating part, you can see the distal CMAP, but there is almost 50% reduction in the amplitude of the proximal CMAP, and there is the waveform is seen spread out, that is called as the increased duration of the compound muscle action potential, which we call in our terms as the temporal dispersion. So the chief findings in the demyelinating neuropathy are conduction block, reduced conduction velocities, and increased temporal dispersion, that is the increased duration of the waveform. What we see in the axonal patterns. In axonal patterns, we see, when compared to the first slide, you can see that there is 50% reduction in the compound muscle action potential in the axonal variants. But what happens in nodopathies and paranodopathies? So in nodopathies, when compared to the distal muscle action potential, the proximal muscle action potential is reduced by 50%, what we call it as a conduction block, but there is no temporal dispersion, that is, the waveform is not spread out, the duration of the wave is still intact, so that indicates an axonal conduction block, which is the chief electrophysiological finding in nodo and paranodopathies. So this is an overview of the antigen targets, the associated neuropathies, and their special features. So coming to the antigen targets at the node, so the chief antigen targets are the gangliosides, the gliomedin, and the neurofilament 186, and these are the associated neuropathies like AMAN, AMSAN, and AIDP, multifocal motor neuropathy with conduction blocks. And these do not have special features. They usually present in our routine clinical context as symmetric ascending paraparesis. And coming to the antigen targets at paranodes are the gangliosides, the neurofilament 155s, and the contactin. Their clinical presentation would be like a CIDP, but anti-neurofilament 155 and contactin have some special features like, and neurofilament 155 antibodies usually have a younger onset of presentation. They are aggressive in nature, and they are distal motor predominant. They have sensory ataxia, and they have tremor, and they usually poorly respond to the first-line therapies like IVIG, and they have an excellent response to rituximab. So coming to the contactin 1 antigen, so this also has a CIDP presentation, but its special feature is they present in older age group, and they have a very rapid and severe progression. Sensory ataxia is predominant. They have good response to steroids, and they are poorly responsive to the routine conventional therapies like IVIG. They are usually associated with nephrotic syndromes and the other lymphoproliferative disorders. Coming to the antigen targets at the juxtaparanode, they are the contactin 2 and the TAG1 proteins and the Casper2 protein, which is implicated in the acquired neuromyotonia, also called as the ISAC syndrome. So coming to Aman, like we deal with this entity in our routine practice. It was initially labeled as an axonal variant of GBS, but so Aman is usually categorized under the axonal variant of GBS. It is seen preceding a Campylobacter jejuni infection, and the class of antibodies targeting the GM1 and the GD1A antibodies are the IgG class. So, but the other antibodies implicated in this clinical phenotype are the neurofilament 155 antibodies. So usually the electrophysiological findings, as the name indicates, it is an acute motor axonal neuropathy. So the name indicates it's an axonal variant of a peripheral neuropathy where we see reduced compound muscle action potentials, but there are other findings. In some patients, we see, apart from this routine axonal presentations, we see other electrophysiological findings in Aman, like I have discussed previously. So they might be a reversible conduction failure without temporal dispersion, suggesting a nodopathy or a paranodopathy. So you have to remember that Aman is not just a subtype of GPS. It can also be a nodopathy or a paranodopathy. Coming to the multifocal motor neuropathy. So multifocal motor neuropathy usually has an asymmetric presentation. It has a distal predominant weakness. So usually electrodiagnostic shows a conduction block. This also presents without temporal dispersion. So the chief antibody targets are GM1 antibodies are seen in 50% of the cases, and it usually offers a favorable response to IVIG. And the other antibodies seen in multifocal motor neuropathy are the antibodies against neurofilament 186 and the gliomedin. Coming to the neuropathies and the at the paranode, so usually we all know about the routine entity called as CIDP. CIDP, the pathophysiology is, it is a macrophage-mediated demyelination. But 10% of the cases of CIDP can also be secondary to the antibodies directed against the paranodal proteins, namely the contactin 1 and the neurofilament 155. So the presence of these antibodies usually favors CIDP, acute onset CIDP, as a favorable diagnosis over the Guillain-Barré syndrome. So how its clinical phenotype is different from the routine CIDPs. So as I've already discussed, it usually has a young age of presentation, aggressive onset, and sensory ataxia is predominant, tremor is predominant, and it does not respond to IVIG. It shows a very good response to rituximab. Why does not respond to IVIG, and why is it highly responding to rituximab is because the antibody targets in the NF155 and the contactin-mediated neuropathies belong to IgG4 class. They do not fix the complement levels. It is complement-independent mechanism that is going on in the pathophysiology of these neuropathies. So normal IVIG works by fixing the complement, works in neuropathies that fix the complement levels. So IVIG washes away the complement, but since these are complement independent mechanisms, so IVIG is like not worthwhile trying in these cases. Rituximab shows a good response when compared to IVIG. So other investigations, they show high levels of CSF proteins and prominent radicular involvement in the MRIs. And the MRI, there is symmetric hypertrophy of cervical and lumbosacral roots. So pathologically, in NF155 antibodies, there is an absence of macrophage-mediated demyelinating process. So it is mainly the IgG4 antibodies, without fixing the complement, are the chief antibodies implicated in these neuropathies. So coming to anti-contactin 1 antibodies, they also have a clinical phenotype similar to CIDP, but they have older age of presentation, and they are, majority of the cases are associated with nephrotic syndromes. So this syndrome is also called as a neurorenal syndrome because majority of the cases, along with the CIDP presentation, in these patients, we found out that they are associated with nephrotic syndromes. So these patients also show resistance to IVIG therapies, and they work better to B-cell therapies, that is the rituximab. So these are the clinical features and their associations. Coming to the neuropathies and the juxtaparanode. So we know at the juxtaparanode, the chief ones responsible there, the chief structures present in the juxtaparanode are the voltage-gated potassium channels, and the main proteins are the Caspr2 and the TAG1. So coming to the Caspr2 antibodies, we know that antibodies directed against the Caspr2 is also known as the acquired neuromyotonia, also called as the Isaac syndrome. So apart from involvement of the peripheral nervous system, there is also involvement of the autonomic, the central nervous system, like they might have insomnia, limbic encephalitis, dysautonomia, and other autoimmune disorders. And Caspr2 antibodies can also lead to chronic neuropathic pain. So this is a slide highlighting the symptoms of Isaac syndrome. So patients with Isaac syndrome can have cramps, stiffness, myotonia, twitchings, fasciculations, and in some patients, muscle atrophy as well. So what is the significance of IgG subclass? So the entire topic, nodopathies and paranodopathies, are being highlighted because of their chief pathophysiological differences and because of their chief treatment variations when compared to the conventional peripheral neuropathies. So we need to know the importance of the IgG subclass. So the IgG is the most abundant antibody among the 5 antibodies, and IgG is divided into Ig1 to 4. Out of these, Ig1 and Ig3, they are potent activators of the complement, whereas IgG4 is complement independent. It does not fix the complement. So IgG4 mediated neuropathies, they respond less to IVIG, and they respond more to the B-cell therapies like the rituximab. So if the patient, this is the treatment protocol for identifying and treating the nodopathies and paranodopathies in the early level. So if an initial patient presentation, if you suspect a nodopathy or a paranodopathy, or if you diagnose the patient to have an AIDP, first test the antibody panel for nodopathies and paranodopathies and start the first-line therapies. So start the first-line therapy with corticosteroid or IVIG. If the patient is showing a good response, go for a maintenance therapy. If the patient is treatment resistant, try, and if the antibody panels for the nodopathies and paranodopathies is positive, go for a second-line escalation, that is, try plasma exchange. If the patient is responding well, go for the maintenance therapy. If still there is no response until 8 weeks, then try the targeted B-cell therapy, the rituximab. Or in the initial presentation itself, if the patient is having an aggressive phenotype and there is early axonal loss in your electrophysiology, so don't waste your time trying all these first-line conventional therapies. So go straight forward to the targeted B-cell therapy, rituximab. So when to suspect, to summarize, so when to suspect a nodopathy or paranodopathy? So it has an acute or subacute onset. So it is predominantly distal motor involvement, but it is rapidly progressive and it is disabling. It has associated features like ataxia, tremor, neuropathic pain. It might have involvement of cranial neuropathies, autonomic dysfunction and respiratory insufficiency and early atrophy. The associated disorders being nephrotic syndrome and the lymphoproliferative disorders. Electrophysiology is the key. It shows the presence of the axonal conduction block rather than the demyelinating conduction block. And the treatment, it is highly responsive to rituximab, less response to IVIG. And coming to radiology, there is a significant nerve root enhancement and enlargement, and histology shows axonal degeneration. So these are the same points. Thank you.
Now the session is open for questions.
We have seen, I think, 2 patients in the last 1 year, particularly the patient, like a young patient coming to us with the history of recurrent attacks of chronic axonal neuropathy symptoms. Sure. He's having predominantly, like as you rightly said, distal weakness predominantly and with severe ataxia. Patient is not responding to our conventional treatment. Then we have sent this antibody and he was found to be in contact in positive. One patient I saw, one of my relatives in Hyderabad, the same complaint, but she an older patient, around 75 years, the same complaints. Chronic like CADP-like presentation, not responding to conventional treatment. Not only CADP, even the AADP-like presentation. AADP patients not responding with like IVIG. We should always suspect nodopathies. Then we should give a trial of rituximab in these patients. Thank you.
Thank you.
Thank you, ma'am, for clarifying these evolving concepts. As we come to the end of this enriching academic day, now vote of thanks by Dr. Sunil, sir.
Good evening all. Just a clarification, I am not a doctor. So since morning she is inviting all the doctors in that flow. She might have called me a doctor, but I am administrative head of this center. Thank you very much. First of all, I thank the management of Kamineni hospitals to allowing us and accepting to conduct a CME program, which is very much helpful for the existing consultant as well as the new generation of consultants. But the turnout is a bit low, but who are here from morning to evening in the interest of learning things and understanding the subject, and they have the interest of learning. And I also thank all the neurology and neurosurgery team and consultants who took all the interest to conduct the CME along with our DNB students who showed their very much interest. I think it is the first time they are participating in this CME in this organization. And I really appreciate your presence and your involvement to making it a grand success. Grand success doesn't mean the number of people who has come. The success means the number of topics which has covered and what are the importance of the topic and what we are going to take home. The specific points and important point which is going to be helpful for you in your future professional career. So, and I also thank Dr. Sridhar Narayan sir and Krishnaveni madam, Lakshmi Prem madam, and very special thanks to Gopalan sir and Jalil sir and Vamshi sir to spending your valuable time and helping us to giving us some suggestions how to move forward, and professionally it is required for our new consultant as well. Thank you very much, and staff and all supporting staff, marketing staff who made this program a great success. Thank you very much, and special thanks to Dr. Vardhan sir, our medical director, who is encouraging all these programs. And hopefully we will conduct one more program in near future in another department. Thank you very much. Thank you all.
Regulations, please control.